So good morning. I, Chair Shelley Bailey, call the Prescription Drug Affordability Board meeting of August 20th, 2025 to order at approximately 8:01 a.m. Pacific. Melissa, can you please call roll?
Chair Shelley Bailey.
Present.
Vice Chair Amy Burns is excused. Dan Hartung.
Present.
Lori Hoagland is excused. Dan Kennedy.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. Our agenda begins with a conflict of interest declaration, which are stated each month according to board policies. Do board members have any declarations of potential or actual conflict of interest? Have board members met with entities or individuals related to board activities, and/or have board members provided testimony to the Oregon legislature about prescription drugs? If so, please provide committee name and date. Do any of my colleagues here today have any conflicts of interest that they wish to provide context on today?
I do, Chair Bailey, please. This is John Murray. Under advisement of the Oregon Government Ethics Commission, I declare a potential conflict of interest due to my ownership of Murray Drugs Incorporated, comprised of 3 independent pharmacies in Eastern Oregon that have pharmacy services contracts with PBMs, insurance companies in the state of Oregon. Thank you.
Mr. Murray, thank you for your information. Before I move forward with the next item on the agenda, are there any additional hands to be raised? Okay, I don't see any further, so I do want to now discuss the minutes and ask members if there are any changes to the draft minutes from our July 16, 2025 meeting. If no one has any suggested edits to the draft meeting minutes, then I would like to ask if we have a motion to approve the minutes.
This is Dan Kennedy. I move to approve. Sorry, John. No, excuse me, Dan. I'll second the motion.
Okay, so with the motion by Mr. Kennedy and the second by Mr. Murray, Melissa, can you please call roll to approve the minutes?
Dan Hartung.
Aye.
Dan Kennedy.
Yes.
Chris Lehman.
Aye.
John Murray.
Aye.
Chair Shelley Bailey.
Aye.
Motion passes.
Thank you, Melissa. We are now moving to an executive session for legal advice pursuant to ORS 192.6602F. The board will now adjourn to executive session for legal advice pursuant to 192.6602F. Representatives of the news, media, and designated staff shall be allowed to attend the executive session. Representatives from the media are directed not to report or otherwise disclose anything said during executive session. All other members of the public may not attend. The public may stay here in the Zoom room. The board will return to open session in approximately 15 minutes. No decisions will be made during executive session. At the end of executive session, the board will return to open session and welcome the public back. Melissa, can you please open the breakout rooms for us to now join executive session? So welcome back, everyone. Melissa, if you could please just call a quick roll to confirm that we have quorum in this room as board members come back from the breakout room into the main session.
Okay, yes. Chair Shelley Bailey.
Present.
Dan Hartung.
Present.
Dan Kennedy.
Present.
Chris Lehman.
Present.
John Murray.
Present.
We have a quorum.
Thank you, Melissa. I now call on Courtney Whitlock to provide us with a program update.
Hey, thank you, Chair Bailey, and good morning, board. I'm here to provide the program update, and I guess to start, I am pleased to share that the governor's office, the legislature, and the DCBS leadership have authorized the board to extend the drug review process into 2026, with a final report due no later than March. With that extension, the board will have more time to evaluate those 16 drugs and the 7 insulin products currently being reviewed. It was requested that a progress report still be submitted by the end of the year, and that report will include the outline of the prescription drug price trends from the list of the drugs received from the Drug Price Transparency Program. The report will also include the current drugs under review, and then any policy recommendations from the board. The policy recommendation conversation will begin next month, so please let staff know if you have any ideas for policy recommendations. Additionally, the recruitment for the PDAB and the Drug Price Transparency Program Executive Director position has been closed, and DCBS is currently reviewing those candidates. And lastly, to follow up, an update regarding the vacant board member's position. The governor's office is still considering applicants, and we hope to have an update for you at the next meeting. So thank you, and back to you, Chair Bailey. You're on mute, Shelley.
Sorry about that. So we are now moving forward to the public comment period for general public comments. Later in the meeting, we will have a public comment time for specific prescription drugs under review today. For the general public comment period, the board received 10 comments which are posted on the website. I will read the letter after this. The board also received 6 requests to speak. I'll go ahead and read who we received written public comment from right now. Harry Gwanter from Let My Doctor Decide Action Network, Primo Castro from Biotechnology Innovation Organization Bio, Lindsay Wiedenex, the Headache and Migraine Policy Forum related to comments on patient access and migraine treatments under affordability review, Mary Kay Clunies-Ross from the Coalition Disease Coalition, McKay Jameson from Patient Rising, Tiffany Westrick Roberson from Each Pick Coalition, she did send 2 letters, Daria McGrew from Pharma, Melody Calkins from Biotech Innovation Organization Bio, Rainier Simmons with CAN, and Susanna Atkins. Related to the individuals who signed up to provide testimony today, the board received 6 requests to speak. I will call on those who signed up and ask them to state their name and organization. Each will have 3 minutes to speak. The board will not deliberate on issues or requests during this time, as a reminder. So the first individual I have on my list is Dean Sewer from the MLD Foundation. Dean, if you are here, welcome, and you have the floor.
Chair Bailey, I do not see Dean yet in the meeting. And if Dean enters the meeting, please use the raise hand function in Zoom and let us know you've arrived. And the same for Silas Martin, who's next. I do not see Silas in the meeting, but if Silas would use the raise hand function, that would be helpful.
Melissa, what I'll go ahead and do is do the next 4 speakers. If you end up seeing raised hands on either, please let me know and I will add them to the end of the general public comment period. So the next individual on the list is Rainier Simmons from CAN. Rainier, if you are here, welcome. You have the floor, and as a reminder, you have 3 minutes.
Good morning. Can you hear me okay?
We sure can. Good morning and welcome.
Hi. Good morning. My name is Rainier Simons, and I'm speaking today on behalf of CAN, Community Access National Network. First of all, we'd like to commend all of your hard work this year. The direction you've taken after pausing to regroup and reassess shows that you sincerely have the best interests of Oregonians at the forefront of your work. It has been encouraging and refreshing to see the thorough discourse the board has been having this year concerning the many nuanced aspects of cost impact to patients and the system, access concerns, and even an effort to examine other affordability measures besides the UPL. However, the current state of the drug review process is concerning. Initially, we were primarily concerned that the number of reviews to be done at each meeting would not allow sufficient time for a thorough affordability analysis. However, after the last meeting, the review process is very unclear. At the July meeting, instead of discussing affordability assessments of each drug, a significant amount of time was spent highlighting issues such as the discrepancies in the data, including incorrect calculations and problems with the presentation or organization of the information in the packets. Additionally, there was discussion that the board has not yet reached consensus on which metrics and the vast amounts of data to focus on as measures of affordability, or what affordability impact even means concerning the drug slated for review. One example of unresolved deliberation was the question of how to utilize APAC versus data call data in determining affordability and impact. The deliberations during the July meeting were thorough and meaningful in terms of fleshing out your concerns with all the data at your disposal. However, the discussion was not what was expected, given that it was supposed to be an affordability review of the drugs. It is good to hear, my understanding is that the deadline for voting on drugs has been extended, but it's still unclear how robust affordability analysis of all three groups of drugs can occur to allow voting on drugs and your extended time period. There are data discrepancies and calculations that need to be corrected. A board paradigm for affordability needs to be established, especially regarding which metrics to use in making affordability determinations, and these measures should be in place to facilitate drug review. At this juncture, the current trajectory of deliberations is unclear, and we don't really understand how things are moving forward. Thank you so much for your time today.
Thank you for being here today. Next individual on my list is Tiffany Westrick Roberson from Each Pick Coalition. Tiffany, if you are here, welcome, and you have the floor.
Thank you so much. Tiffany Westrich Robertson, Ensuring Access Through Collaborative Health and Associated Patient Inclusion Council. I'm also a person living with non-radiographic axial spondyloarthritis, which is an autoimmune disease. I just want to thank you again to the board, to staff, everybody for your continued efforts in this review process. We are concerned with the process moving too quickly, but we are also happy to understand and hear that there is an extension into 2026 for decision making. But I do still want to focus today my comments on the importance of finalizing the methodology. In particular, you may or may not know, but my expertise is building innovative solutions from scratch. So I do understand thoroughly the trial and error process. It takes time, it takes persistence, and I applaud all of you for doing just that, the time and persistence into it. I do just want to also say that simply that in the nature of doing something innovative, that there is a process of trial and error, yes, but the process also involves then going back to the table, revising, putting it back on the table, and launching it when it is ready and it feels right to all. And after watching the last board meeting, I'm concerned some of the board members may not feel like it is like we're ready to move forward. Also, the public surveys to date have had low participation rates, making it unclear how patient perspectives will be incorporated. And the surveys used are not capturing the very important missing why someone can or cannot afford their medications, which is a vital component to solving any problem. Given the lack of participation from patients, I do urge the board to read our newly released patient experience prescription drug affordability and unaffordability pilot study. Clearly showed that retail cost of a drug is not impacting why a patient reports their drug unaffordable or not. Example, 0% paid 0 to 10 and reported those unaffordable. But why? It was insurance complications, accumulators, low income levels, and accumulative costs. 100% said they stopped taking a drug with unaffordability, but the why was captured in open-ended responses: insurance denials, prior authorization, step therapy, and no copay assistance on Medicare. The fact of the matter is we need to know the why, and we want that included in any of the board's decision. To truly improve affordability, process must be deliberate, transparent, and rooted in shared patient-informed criteria. Thank you so much again for your time and listening to my feedback.
Thank you for being here today. The next individual we have on our list is Daria McGrew from Pharma. Daria, welcome, and if you're here, you have the floor and you have 3 minutes.
Good morning, Chair Bailey, members of the committee. Thank you. For the record, Daria McGrew on behalf of Pharma. I'm glad to hear the announcement of timeline extension today. It's probably wise to pump the brakes and give yourself more time to work more of this out before decisions are made. First, I want to address the draft scoring framework presented in the meeting materials. Appreciate that this is a step towards a more consistent and transparent scoring approach. The rubric as presented in this month's packets is woefully underdeveloped, and I encourage the board to request significant revisions and further evaluation during your discussion before it could be used for any meaningful scoring of drug reviews. As a first draft, it contains many errors and inconsistencies. Terms need to be clearly defined. Quantitative cutoffs need a rationale described. It just needs to be further developed. And I appreciate that the rubric recognizes many factors that impact affordability, like access and burdens put in place by plans, and we ask that be teased apart and fully explained the rationale for all of it. I want to discuss generally some of the data elements in the review packets. There are many questions that stakeholders have about the data that we're seeing and would be answered with a comprehensive data dictionary and more clear methodology. It is crucial that stakeholders be able to understand and replicate some of the work that is done by the board. There are many terms with vague meanings or have different meanings to in different places. Spend, cost, reimbursement, these are all related but have different meanings and shouldn't be used interchangeably as they sometimes are in the reviews. Why are payer paid and plan spend two different things? What is the difference that is intended by that? It is not clear. In many places, you're talking about total cost to the healthcare system, but that is total net cost, which is confusing, or total gross cost and not total net cost to the system, or they're used interchangeably. So those need to be more clearly fleshed out. And again, as was mentioned last month in the first set of reviews, there do appear places where net pricing is higher than gross pricing. This can't be explained simply by two different data sets, because even within the carrier reported data, there are tables where total annual spend, theoretically net of rebates, is higher than the number reported in another table, still data carrier reported, but price after concessions. Why don't those things match up from table to table? There could be many reasons why. We ask that the reports and the board clearly address those and explain them or explore them in the documents moving forward. Thank you. Please see our letter for more details.
Thank you for being here today. Next individual I have on the list is Derek Flowers from the Value of Care Coalition. Derek, if you are here, welcome, and you have the floor and you have 3 minutes.
Thank you, Chair Bailey. Good morning, and thanks for the opportunity to comment. I'm Derek Flowers. I represent the Value of Care Coalition, a network of patient, healthcare provider, and caregiver organizations. In May, the coalition shared concerns with the number of drugs selected for review and the timeline provided to complete reviews, emphasizing the need for quality over speed. At the time, we said, quote, concerns arise about thorough and accurate data compilation, analysis, review, and deliberation. A process that prioritizes haste over rigor may lead to an erosion of public confidence in the process and its outcomes. Unfortunately, those concerns proved valid. During the July meeting, data compilation and analysis being utilized were found to be inaccurate, as noted by commenters and board members alike. Likewise, deliberation was not sufficiently thorough, with even board members confused about whether any future meetings would be devoted to discussion of these drugs. Also in May, the coalition said, quote, each treatment comes with their own value, known best by the patients who rely on them and the doctors who prescribe them. Cost and value are not the same, but these perspectives of value should be central to any discussion about the cost and affordability of a drug. So to that end, the coalition recently released a report highlighting the perceptions of specialists in states with PDABs regarding their operation and the potential use of upper payment limits. Although the Oregon board doesn't currently have UPL authority, there's no denying that decisions about affordability made today may underpin future discussions about upper payment limits if and when it's granted. Unfortunately, the report shows that specialists are concerned that PDABs haven't sought their input. 93% did not believe there was sufficient knowledge sharing between boards and healthcare providers, and this led to the second concern. Healthcare providers aren't being included in decisions that will impact health outcomes. Regarding therapeutic alternatives, doctors surveyed reported that 41% of their patients fail a first-line therapy. Perhaps because of this, the majority would not even be willing to switch their patients to a therapeutic alternative in the same class. As such, 93% are concerned that PDABs unaffiliated with state medical boards will make decisions that could hinder patient access to needed medications. And finally, the administrative burden in patient care is top of mind for healthcare providers. Every specialist surveyed, 100%, was worried that PDAB decisions would create new administrative work that would cut into patient care. Many anticipated more insurance paperwork, more denials, more appeals, and more time fighting for coverage. 96% were concerned upper payment limits would lead to non-medical switching, the forced switch of patients from one drug to another for reasons unrelated to health. I share these points today not in opposition to improving affordability, but as a caution of the risks of making determinations that, by specialists' own account, are not informed by the people who truly know the value of these treatments. We urge the PDAB to ensure these concerns don't anticipate foreseeable outcomes as accurately as the initial concerns about flawed data and unclear processes. Clinicians, the people who know best how these medications work, who understand what happens when treatment plans are disrupted, they're raising serious alarms, and they're not alone. These concerns build on statements from pharmacists, health plans, think tanks, and patients. Please consider what they're saying. Thank you for your work on such a challenging and important issue, and thank you for the opportunity to comment.
Thank you for being here today, Mr. Flowers. So I see that
Chair,
yes,
excuse me, Chair Bailey, it looks like Silas Martin has arrived.
on the next speaker. Appreciate your
Yes.
time, Melissa. Thank you. So I
Yes.
would like to now welcome Silas Martin from Johnson & Johnson. Silas, your appears that you are here, so welcome. You have the floor and you have 3 minutes.
Thank you. I'm trying to turn on my video, but I don't know if it's active, but I will start.
We
There
can
it is.
see you.
Perfect. Hello, everyone. I am Silas Martin. I'm the head of Access and Policy Research at Johnson & Johnson. Thank you very much for the opportunity to discuss the Oregon PDAB's processes and methodologies. We respectfully ask the board to take 4 actions. First, we'd like to clearly define the word affordability. So the criteria and methodologies for conducting affordability reviews with the opportunity for public comment on those. This procedural step should be completed before any reviews are conducted to ensure that we have accuracy, transparency, and scientific rigor. The second thing I'll say is we'd like to correct calculation errors that appear to be in the PDAB data dashboard that we believe mischaracterize out-of-pocket cost estimates for patients. For example, for many, if not all, the drugs on the dashboard, the average copays, coinsurance, and deductibles were added together to calculate an average enrollee paid per claim and the average paid per enrollee. So typically plans offer, either a copay or a coinsurance, and so not both together. And so we believe that this may inaccurately characterize that out-of-pocket costs. Third, we remove irrelevant data from the dashboard. Showing Medicare data is perhaps irrelevant for this board, given that that's regulated by CMS and not Oregon. So that's one. And then the fourth, we would allocate sufficient time to thoroughly review each drug. Currently, the amount of time that's allocated, 5 to 6 drugs per meeting, in addition to other topics, appears to be quite substantial. And that we believe that having a public dialogue about this, the drug's value and affordability with proper time is important. Lastly, so for these points, we want you to refer to our data submission in supplemental materials. But the last thing I'll say is we saw recently the PDAB released the new proposed rubric for guiding affordability reviews. We appreciate that transparency, but we anticipate a future comment period to foster public feedback on that rubric. And we know that patients are counting on us to develop and bring to market these accessible medications. We at Johnson & Johnson live this mission every day and are humbled by the patients who trust us to help them fight diseases and live healthier lives. I appreciate the time today for comments.
Thank you for being here today. I do want to circle back and see if Dean Shore from MLD Foundation is in attendance. Melissa, if you can confirm or deny if Mr. Shore is here today.
He is not, Chair Bailey.
Okay, I appreciate that. So we will be now moving to the next portion of our agenda. So we are now reviewing the board review of methodology for drug reviews and scoring rubric and worksheet. So the board is conducting drug reviews per ORS 646A.694 and OAR 925-200-0020. At the July 16th meeting, the board reviewed 6 drugs in Group 1. Today, we will begin the review process for Group 2. There will be public comments for each drugs under review per ORS 646A.6943. Each speaker will have 3 minutes, and the board may have 1 moment. Staff, can you confirm this is indeed the section that we're doing right now?
Yes, we are ready for.
Thank you. Then I'll continue. Board members may have follow-up questions for the speakers. The board chair has a discretion to extend speaker time, but the board will discuss methodology for drug reviews and scoring rubric and worksheet. These documents are included in today's agenda materials. I do now call on Courtney Whitlock, Senior Policy Analyst, to get us started. Courtney, you have the floor.
Thank you, Chair Bailey. I am going to share my screen to get the conversation started. I wanted to provide a highlight of kind of the roadmap of where we're at and what's got what has gotten us through this process. There we go. All right, so we've done a lot of work over the last few months to get us to the point of kind of really diving into the drug review process. I know we've heard a lot of comment about not knowing exactly how the process is being structured. The material packets are just structured information for the board. With the decision-making and collaborative discussions broke out for groups of drugs each month with a more deliberative conversation. Now probably going into the first part of next year, now that we have that confirmed extension from the governor's office and DCBS leadership. So again, we're here in August. It is our intention to at least have conversations around the drug 2 or the group 2 drugs to review. The surveys are still open. We have not really received much information on those, but we do incorporate them into the material packet as they come in. And then just knowing that group 3 will be the anti-diabetics next month, with the insulin products being in October. However, again, those will probably be extended out a little bit more so that we can also start incorporating the conversation around the policy recommendations to meet our end of year reports. One of the conversations I wanted to kind of just highlight today is how we got to defining the 16 drugs that we were at. We've had some comments coming in of how did we get to where we are today. So I just wanted to just refresh the board that the preliminary list that we started with was 158 drugs. We did our first drill down to this first subset list so that subset list could go to the carriers for the data call information. And through that process, the board removed 62 orphan designated drugs, 25 generic identified drugs, removed the vaccines, toxoids, and diagnostic products, as well as any drug that had a known generic, and then also filtered out if 5 or less, so 5, 4, 3, 2, 1 carriers reported didn't have it show an impact for that drug. And so that resulted in the subset list that was sent to the data call to be 27 drugs. When we got the information back from the data call, 4 additional orphan drugs were identified. So those 4 were removed. And then the board, looking at the time the dashboard was developed, and numbers were, APAC numbers were also incorporated along with the updated data call information. And the decision to remove drugs that had less than 500 APAC enrollees were removed. So it took us down to the current 16 drugs that we currently have. I intentionally didn't incorporate the insulin stuff because the conversation basically just resulted in the list that we're going to be reviewing in the next couple of months. So again, the breakout of the drugs, the 16 drugs, are group 1. We reviewed or began the conversations. We began to introduce what those drugs were, kind of the impact, and board provided staff with additional feedback since it was the first time that you saw the material packets kind of put together with additional information how to improve the packets for review. We applied those reviews into group 2. We will go back and update group 1. Again, it's a lot of work for 1 or 2 staff members to do, so we have to kind of parse out the priority. So group 1 will be updated with the updated information in it. It's just we have to get through the groupings first, and then we'll go back to so that those packets will be updated for your final deliberation conversation. And again, starting next month, we'll do the anti-diabetics and then the insulin products, which are focused around the insulin glargine. So before I move into the next conversation points, is there any feedback or information or questions from the board members on how we've gotten to where we are today? All right, Hearing none, hopefully that review was helpful. I'm going to stop sharing my screen.
Hey, Courtney.
Yeah.
While I don't see the raise hand feature on this version of Zoom right now, I did want to, I guess, orally raise my hand and say that I did miss one speaker during the public comment period. So can we go ahead before we move to your next piece of this and add time for that speaker?
Yes.
Okay, so I appreciate it. Sorry for interrupting you. But one individual who did request to provide oral testimony today is Lauren Sant from the Caring Ambassadors Program. Lauren, welcome. You have the floor. And again, my sincere apologies for making that error.
Good morning. Thanks, Chair Bailey. I appreciate you making time for me today. Good morning, everybody. My name is Lauren Sant. I'm the Executive Director of the Caring Ambassadors Program based in Beaver Creek, Oregon. And I do want to thank you for all your hard work that you're doing to address the impact of high-cost prescription drugs faced by Oregonians. Before I do talk about my comments that are already submitted in writing, I really just want to state that the agenda really needs time listed for each drug that's being reviewed. It's not realistic or respectful to ask providers or patients or caregivers that want to participate in this process to sit through a 4-hour meeting. And while I understand they can submit their comments in writing, it does not give them the board the opportunity to enter into a dialogue and true patient engagement. Super happy that you asked for an extension. Thank you. I think that's a huge development and really glad that you're doing that. And it shows that you are dedicated to making this process work. So thank you. And I'm really pleased to see that there's a new rubric in development for consistent methodology. However, I'm concerned that the scorecard lacks transparency to its origins and whether the board has voted to approve it and the language and the scoring. I don't see any patient input in this, which is critical to the process. And I wanted to know if there's going to be any opportunity for us to have any input into the rubric moving forward. But if not, I know it's moving forward, so I hope that you will consider a few points. Therapeutic alternatives. In the realm of medicine, therapeutic alternatives, therapeutic equivalents, and biosimilars are distinct categories and are not interchangeable or considered equal in the same way and should not be in the same domain. Additionally, I don't understand the scoring in this domain. If there's no effective or affordable alternatives, then why would it receive a severe impact score? Is this approach solely focused on saving the state money? It's crucial to consider this from patient perspective. There's no alternative. It's not in their interest to have a higher score. A patient-centered approach is essential to your evaluations. And your stakeholder input. You have listed minimal stakeholder input as low impact. Are you sure? Was there proper outreach to the patient community to ensure that you're hearing from people that are prescribing these medications? Why are only concerns about cost evaluated? Why aren't other concerns considered? Have you edited your patient survey posted on the website for drugs still under review to reflect the issues raised in the July meeting by board members regarding the relevance of the data gathered? I do want to point out, if you haven't read the Each Pick survey, 100% of the patients, as Tiffany said they stopped taking their drugs due to affordability, cited insurance reasons. Please read that paper. It's really important. And in the framework, there's no mention of how the scores will be collated or calculated as a whole. There's no definition for the scoring interpretation. It's very subjective, and each board member may review these differently.
Ms. Sam, thank you for your comments. I appreciate it.
You.
You're at time.
Thank you.
Thank you.
I appreciate it.
On this. Take care.
Yep. Thank you.
Courtney, you now have the floor related to the next slide that you were moving forward with for the board.
All right. Thank you. Let me get my screen shared again. Well, following the comments, we are going to be talking about the proposed rubric kind of process to see how the board wants to incorporate this proposed option. Again, I appreciate all the comments from the public. This was a new concept. The board has not had time to deliberate on it. That's what today's meeting is about. So hopefully there'll be some more clarification about the process and structure of the rubric and the setup of the key questions and process for this, and then how the board wants to utilize it. So all the board members have received this or have had some sort of view into this. And so I really want to open up for the board. I believe the foundation has been kind of laid, but it really needs, staff needs to lean into the board conversations on how this possible methodology will help determine the review of the drug packets and the cost impacts that are statutory required to determine. And I want to start off with first like the key question components, and then we'll move over to the rubric. I guess to start with how this was broken down was that the domains follow the statutory requirements. I just kind of titled them, based on kind of where they were in the packet and how they reflected in the statutory or rule. It was referenced that, and then how the packet sections equated with each different section, because there's multiple sections for each of the domains. And then I just looked through the material and kind of asked some standardized questions from what I thought was relevant to be asking for that domain. However, again, leaning into your professional expertise, is there other concepts, questions that can be asked in order to strengthen the rubric?
I do want to kind of a workflow related question. Can you confirm on your version of Zoom right now if you can see the raise hand feature for individuals? Because I do not, and so I just want to see if other board members see that feature. Otherwise, it may be good for us to turn on camera so we can just see when people want to say things, because I do not see raise hand.
Chair Bailey, if I go to react, then I can see raise hand. So I think I'm able
Maybe I just
to do it.
Yeah. Okay, on mine I cannot. Can other board? Oh, Dan raised his hand. Everyone else can raise their hand. Okay.
Yeah, good. It's the react section.
Right.
So if you can't see that, it may be hiding.
Okay. Well, I'll work on it on my end. So thank you.
Yes. But if you can't see it, then just raise your hand or just interrupt me if I'm speaking so we can have the dialogue. So starting here, did any of the board members have any questions or concerns around the initial structure of setting up the domains and the key questions? And I see a hand up from Primo Castro. Melissa, are you able to remove that?
Yes, I can do that.
Thank you. I don't have, but Dr. Hartung, I see your hand up.
Yeah. I guess my first comment is that I generally like this concept of clarifying our thought process. I'm less sure about the scoring, the explicit scoring of it, but let's put a pin in that for now. But there's one discrepancy between, well, probably more than one, but one domain discrepancy between this document and then if you go to the scoring piece, where in the first section it says population impact and equity, and then if you go scroll down to the scoring rubric, it says access and equity considerations, and there's some differences in kind of what's discussed in both. And so probably need to clarify what is going to go into that with this domain. I do think we need a population impact domain, as you have, where we kind of talk about the number of Oregonians, and then the number by payer group, I think is helpful for kind of determining, how much these drugs affect the population, as well as equity issues based on kind of the summary of your evidence. I really wish we had equity specific issues specific to the state, but maybe the next go around we can do that. So that's just one domain issue that needs to be clarified. streamlined and corrected, I guess.
Well, then I'm going to put that back to the board. As Dan or Dr. Hartung kind of mentioned already, the focus of, you know, the equity. What does the board prefer? This is going to be your, you know, this is for you guys to have this discussion. To, yeah, Chair Bailey, I see your hand up now.
Finally figured it out. My apologies. So Dr. Hartung, just so I understand it right, for this first kind of comment related to domain, were you suggesting that you were looking for essentially all the domain titles to be the same? Like for us to
Well, it's more than titles, like there's different
the context in the content.
Yeah, so I would say it seems to only reflect that first one primarily that I could tell, but like I would say we have population impact and equity as one domain, and then access maybe as a domain that's not even here, and then where we talk about issues about coverage and enrollee barriers, you know, so we have, you know, in this access and equity, we have non-preferred formulary stuff in here, which is, I think we need to talk about, but I think we can kind of like maybe add another domain that's like access, and then have the top domain be impact and equity. Just kind of creating another domain, basically.
Kind of like what I started here.
Yeah, I would say the top one would be impact and equity considerations. This is just my opinion.
And while she's making that change, Mr. Murray, I see your hands up, so you have the floor.
Yes, thank you. I agree with Dr. Hartung. I do like the addition of the access domain, particularly where, you know, we start hearing from public comment and things about affecting affordability. And for example, administrative burden, I would think would be part of access, in my opinion. What level of encumbrances are there to obtaining the medications under consideration for a patient?
So one thing I think, well, a couple things I wanted to acknowledge. I really want to thank Courtney for coming up with something to kind of visually convey to us based on hearing all of our feedback in the July meeting. So I know this is a completely new approach, but I know it was very much based on the feedback we gave from July. So I just very much want to thank you for the effort put in to help us get to where we're at right now. Number two, I was thinking before we go through the content in each of these sections, do we want as a board to have a discussion, I think, about how this might be used? I personally have my own personal opinions about, you know, how this could be incorporated, but I think before we go into everything we may or may not want in it, maybe that's a discussion that we should have right now. I'll go ahead and share, if there's not a raised hand, I can go ahead and share my personal thoughts related to it. One personal thought I have related to this is this has provided us some really great things to think about as individual board members, but from my personal perspective, in no way, shape, or form would how any individual board member or even the board as an aggregate score necessarily mean when we have our final vote that is, you know, the quantitative, you know, formula that we use. I look at this as a tool that we may use as we're personally thinking about this as we go through all of these meetings, but not necessarily that how the math kind of ends up on this is exactly how we would go. But that's just my personal thoughts, but I can see others have some. So Dr. Hartung, you have the floor. But we cannot hear you.
Yeah, I kind of agree with you in terms of, the scoring is going to be challenging. But just as a way of thinking through these issues, I think this is very helpful, or if we refine it, I think will be really helpful. Well, one question I have is about process stuff. Like we've already done a set of drugs last meeting, and we're giving another set of drugs. So, are we going to revisit this thing at the end after we read have we gone through all the packets, and then kind of almost use this to look at review all the drugs with these various domains front of mind to kind of make the decisions about affordability of the drugs we've reviewed? Is that kind of where we're headed?
I think that's yet to be determined. In my personal opinion, I feel like that could be something that's very helpful at the end, that, individual board members could all have their own perspective or rank even on the rubric in general, or how they would score things. And that it would just be a tool that we could use at the end, but not necessarily the only thing driving our own individual decision-making process. That's how I would look at it. And I would suggest that at the end we look at all the drugs in whatever context like this we might want, or other factors that are meaningful to each board member. That's the way I personally have been kind of viewing this, but clearly I think that's something that the board today should discuss and decide on.
Yeah, and to follow that, I mean, that was the intention of developing this, was to, again, kind of provide some sort of baseline structure. And it doesn't have to be set in stone. It's kind of a tool. It's a concept. We're happy to change it, to create it to be the best way to evaluate the drugs that are under review. And Dan, regarding your comments, again, the first group material packets are going to have to be updated anyway. All these packets are what we're calling rolling packets, so they're constantly staying live. They're going to be updated as public comments come in, as patient surveys come in. So really, until the board is ready to sit and make a decision on each of the drugs, the packets continue to have information incorporated into them, which, following kind of how the rubric is set up, and maybe even the scoring methodology, as the packets are provided, or as the board's provided with the information from the packets, you can kind of conceptualize how the scoring would be. And I know I developed this kind of concept worksheet to kind of help, just fundamentally, and we played around. So all the drugs are in here in the drop-down menu, and then each board member's name, make it easy. But just as a concept, as you review the drugs at your leisure, you can say this drug has, you consider it to have a high impact to equity considerations. And then what it does is it starts totaling it. Again, as we're talking about process, you can take this and use it at your own discretion, and you can also use it as kind of towards the end, when the board's ready to make those decisions, as a metric. And I can create an online link that the board can maybe do like a live assessment of each of the drugs, and then kind of determine how each board kind of views the drug itself. So again, there's all sorts of ways that the board can take this information and make it into what is most meaningful for these drug reviews and the concepts for the board to make the decisions. Yes, Chair Bailey, I see your hand up.
Thank you for providing that clarity. I know this is, the intention of us talking about it today. And again, I would just reinforce my personal opinion that even if we do any sort of forms or anything at the end, with real-time voting, that it still is just a tool for us, but it does not, in my opinion, need to be the only thing we use. We can still lean into, if the board member may disagree with how the general poll came out or whatever it is at the end, but we still, in my opinion, we don't need to solely rely on this. This is just something to help us personally as we think about things in each of these meetings. Are there other board members that have some feelings related to this? Because I would like to essentially decide related to that. Mr. Murray, I see your hand is raised. You have the floor.
Yes, I appreciate the framework of many of the concerns about affordability that I've had over these past couple of years. They are represented primarily by the ones listed as domain. I do appreciate the teasing out of access from population impact and equity. I think that's a positive step, a bit of information that we do need to know. Is it perfect? No, as public comment and people have commented on, for example, therapeutic alternatives, equivalents versus biosimilars. Yes, there are issues with that. As a pharmacy practitioner, I understand exactly what the specialists are talking about whether this medication applies for this particular patient or not. I don't know how to consider our task, though, without some consideration of these kinds of issues. I understand the need for step therapy and cost containment, for example. Do I like it? No, I don't. Is it cumbersome to patients, especially when they change insurance plans each year and they go through it yet again? Of course, it's a tremendous issue. So again, this isn't perfect, but I really appreciate the effort made to put this together, and I will use it personally with caution based on my experiences, but it's still very helpful to me.
Yeah, Chris, I see your hand up.
Yeah, Courtney, I mean, I agree with John 100%. Thank you so much for all the effort and time you put into this. I think the board has been trying to express, a desire to have some sort of framework, whether or not it's the exact framework we're going to use to make decisions or just to help guide us. I appreciate, this addressing the board's concerns and also the public's concerns, because so many of the letters that we've received over the last year have said there's no transparency in terms of how decisions are going to get made. And so this gives people sort of the idea of general principles of what we're going to use to make the decision. And of course, there may be other factors that our experiences bring into the discussion that affect how we, choose to make decisions in the end. But I feel like this is very helpful. So, Chair Bailey, I'm great with using this type of framework or, an edited version of this to help us going forward.
Thank you, Chris. Dan Kennedy, I see your hand up. And
I guess we lost Dan.
Okay, I'm here. I was on mute. So yeah, I would just echo what the other two speakers said. I think this framework is great. It lends a degree of consistency to the process, which I think is really important. I would just caution that keeping this as objective as possible so that we can have a comparison of drug A and drug B to be consistent on both sides. And that's, I would just echo and say, great job, Courtney. And I think it may not be the final product, but I think this is definitely on the right path.
So hearing that, if I could do a listen check, because I do want us to provide, although, board members have seen this, in the meeting packet and things, I do want us to move into providing that type of rich feedback that we wanted to give staff. I do want us to do that in this meeting, but just as a listen check to advance our discussions, what I believe I'm hearing, but please speak up if someone feels differently, is this is a tool among other tools we may use for decision-making purposes, that when we're at the end of the affordability reviews for this cycle, we may elect to use when we're looking at all the drugs before voting, but it is just one tool of our decision-making process. Am I hearing that accurately as the will of the board? Okay, if anyone differs, please say no, and then state an alternative. So with me hearing no no's, let's now move into providing Courtney with that rich and valuable content that we might be looking to provide so that we can enhance these discussions. And so I know Dr. Hartung had started off by providing, breaking out some access and equity into some separate domains, but Mr. Murray, your hand is raised and you have the floor.
Thank you. It would have to do with price concessions. It was a topic that we discussed a little bit. A high percentage of claims discounted doesn't necessarily mean that the drug was substantially impacted in the cost to the plan or the patient. I would say the percent of discount would be more important than the percent of claims discounted. Or how do we incorporate both? I guess if only 10% are discounted highly, how do you rate that? I'm looking for what price concessions affect payer or plan and patient out of pocket or costs, please.
Yeah, so
And
give
what,
me just a second, I can go. So how I pulled that, apologies, my system.
if I'm hearing you right, Mr. Murray, you're saying that you just want to know essentially that there's a high discount off whack. Is
Mhm.
that what you're referencing essentially for the claims in that bucket?
Yes, yeah.
Yeah, and so I pulled that basically from this percentage that we got. So if there's a high percentage, but then there's also the remaining after concessions that maybe the board would want to look at, or
While she's doing that, Dr. Hartung, your hand is raised. Do you have the floor?
Yeah, I agree with John Murray 100% that it probably should just be like what the percent rebate was or percent concession. And it's unclear to me why some of these drugs have, you know, in reviewing the packets this month had like, you know, 95, 90 to the high 90s of claims that had concessions versus other drugs there's pretty low. And so I'm a little, I don't know if that's a data issue or if that's actually what's going on, but that's another issue. But focusing on the overall rebate percentage, I think is what we want to highlight.
okay. Sounds good. And then I can apply that to the rest of these. I don't want to do a whole bunch of the edits online, but so the percentages are based off of APAC and data call information for this drug review. Worked with a data researcher, Pay, and we spent some time ensuring that all the ranges were within the range of drugs or within the scope of the numbers and percentages represented here. So they're not made up numbers or anything like that. We did take time to go into each section and say this amount is this percentage and this amount is this percentage. So, Chair Bailey, I see your hand up.
So am I hearing you accurately to say that when you went into APAC, there's already a methodology for what constitutes a high rebate or what constitutes a low rebate? I mean, obviously, I immediately start thinking of the 340B drug discount program and what those rebates look like. So how did we think when we pulled the high? What does high mean? I guess because I'm assuming that's something we would want to know. Is that
So again, all of it is in the packet in some capacities. So like when we're talking about price concessions, it is based off of these numbers. And Dan, I'm happy to go back with Hay and Heather to determine if these numbers are accurate.
because I think the question, and I hear what you're saying, it was based off this, and I think what the question or Mr. Murray was asking, and then Dr. Hartung and myself is, I think we were trying to bucket it based off the WAC discount, right? which may be much more difficult for us. I mean, meaning high could be claims discounted X% off WAC. And
Yeah, my understanding, this is carrier data. This is from the data call, and this is basically just the difference between the gross and net, which is roughly, you know, percent off of WAC, you could say as well.
But I do hear what you're saying, Courtney, that you did work with Pay on figuring out what those high, medium, or I guess low discounts
What the ranges are, yeah.
were.
Because again, we wanted to make sure that any of these sections are identified in the packet themselves from information. So, I did want to go back to Dr. Hartung. Of the price concession looks to be reasonable, to kind of focus on how you would like to provide verbiage for these scoring methods, since most of this is based off of access to some
Yeah, I mean, in terms of like how to create the cut points.
Yeah, if possible. Otherwise, I can continue to work and collaborate with the board until next month. I just want to provide as much information here as a board project to get this shored up, and not just based off of doing it before the next board meeting. So if there's anything within these scoring
Maybe we should focus on the actual metrics that we're going to look at and leave the cut points for later, because that's where it gets real dicey, and like what's a good rebate, what's a bad rebate, you know, that's really tough question. What's a lot of Oregonians, what's not a lot of Oregonian, you know, these are kind of somewhat subjective questions. So, but if we focus on the metrics for each domain, I think we can, you know, with the data we have, we can kind of get that nailed down. If that makes sense.
Yep, absolutely. Is there another domain you wanted to look at? Since we just did price concessions.
So Dan, is there a metric that you're thinking of for impact and equity that's separate from the access or the enrollee burden metrics that Courtney has in there?
Well, I had thought, I was just thinking about this, you know, impact and equity. I like the notion of having like some quantification of the number of patients in Oregon who are taking the drugs. So like, and then that broken down by Medicare, Medicaid, commercial. And so that's easily quantifiable with the APAC data. And then equity, you know, in our packets, equity has just been tackled with like a summary of the literature about equity in the disease state. And so so it's not really as data driven, or at least internally data driven. And so, you know, some sort of high, and my guess is all these drugs are going to be, you know, any sort of equity literature that's been pulled is going to really show some disparities in access. So, but, you know, some sort of, that's going to be more subjective based on the literature summary that's been done by staff. So it's not, it's a little less data driven. And then the access issue, this access domain, I was kind of thinking, well, if we could do something about using the, you know, number of plans, a proportion of plans that don't cover it, and then the proportion of plans that have different policy barriers like prior authorization, step therapy, non-preferred. So kind of that domain covering all just the plan coverage. And again, how do you break that down based on like high impact versus low impact, I think is another challenge. But at the very least, figuring out how to measure it based on the data we have, I thought those would be reasonable.
Okay. I can work with that. I kind of had that here, Dan. Plans listed drug as non-preferred, preferred.
Yeah.
That's
Yeah. So I like that. And then
okay.
but there's also stuff in enrollee burden because you have stuff on the prior auth and things like that. So my thought was just to move that stuff, have enrollee burden being all about out-of-pocket costs, and then move all the policy stuff to this access domain to keep it all in the same
Okay. So like
line of thinking.
yeah, this stuff.
Yeah.
Okay. I will get those updated. Thank you for that suggestion. Anything else? Or did I kind of?
So John, I know, Mr. Kennedy, your hand is raised. You have the floor.
Yes, I just have a quick question. On the left-hand rubric under system and payer costs, in the very far column, we have Medicare included again. Do we want to include Medicare in this? Because we've pretty much excluded Medicare and everything else.
So Medicare is only excluded when it comes to patient out-of-pocket cost information because majority of Medicaid. So, but we do look at Medicare.
Okay.
So yeah, Medicare is still part of the line of business that data has been pulled in from APAC. Because if we're focusing on APAC information, it covers 3 lines of businesses, which is the commercial, the Medicare and Medicaid, where the data call only incorporates 11 commercial carriers that are required to report into the drug price transparency program. So APAC has a larger database of what's going on in the system.
Gotcha. Thank you, Courtney.
So as Courtney's making these changes, I know some board members have referenced that this may not be perfect or they may have some thoughts on different pieces. Are there, because this does impact kind of how, kind of how we think about this. So are there any other specific parts of these that board members would have questions on or have feedback that they may want to provide another way? Again, I know we shared this previously on our board's website, but Mr. Murray, I see your hand is raised, so you have the floor.
Yeah, I mentioned therapeutic alternatives, for example, in my previous comments, and it still persists for me. Various comments that are made and public input about what our final determination of affordability or not. I know it's based on many things here, but what is going to be the effect on a patient's ability to get a medication? Is it going to increase, as some people have alluded, some input, that it's going to increase administrative burden? And so I've got a swirl of thoughts under this therapeutic alternatives that I need some input from others to help work through, please. I know the need of, well, anyway, I'll just leave it at that. It's difficult for me to go with the therapeutic alternatives and make a determination. So I need some input from other board members, please.
Is your line of thinking that you, again, for the record, I'm not a clinician, is your line of thinking that you would like therapeutic alternatives somehow broken down into separate biosim. Or anyways, I'm just trying to understand the help, but we have a doctor here who hopefully can help collaborate on this. Dr. Hartung, your hand is raised. You have the
Well,
floor.
well, I don't want to interrupt if you're.
No,
if you're
I was just
making a
trying to
point.
tease out. I was just trying to tease out, is Mr. Murray seeing this as like a separate section, two separate sections because of the biosims, or what particular additional thoughts from board could help him in bringing forth his feedback in a way that presents it how he's thinking. And maybe he's just still pondering, but
Well,
Hartung, which we're all doing, right? So
yeah,
thoughts on that.
I appreciate the comment from John about this, because I've thought about it, how best we think about this issue, and I'm wondering if we, you know, I feel like therapeutic alternatives, or whatever we call them, basically different drugs that are used to treat the same condition that may have equivalent efficacy, or they may be kind of true Me Too type drugs, or they may be slightly different and maybe a little less effective, but they're all in the kind of toolbox of clinicians for this particular disease. But I'll call them therapeutic alternatives for short. But should that be threaded through all these different domains, rather than, it could be its own domain, but should it be threaded through all the different domains, in terms of like, so board members can think about, like for instance, price changes and relative list price of the drug, the subject drug versus the therapeutic alternative, price concession. It's even in the rubric of like concessions of the subject drug versus other alternatives, system costs, of the subject drug versus other alternatives, enrollee burden. So, because we've started to move down this road of, in the packet edits that have been made, of making sure that we have the therapeutic alternatives for comparative purposes. And I think that's helpful for putting things into context. So that's kind of what I'm wondering, if we want to either
So
remove this as a domain, and then with purposeful intentional threading throughout the other domains, or thread it to the other domains, keep this as its own thing. I'm just throwing that idea
because
out.
to your point, the packets have been enhanced so much that we have it in the packet, but you're essentially trying to thread it into each of, I hear what you're saying on that. I do not know logistically what we can and can't do, but that makes sense to me, Dr. Hartung.
Some of the stuff we can't
She's
do
showing it.
because,
Oh, yeah, it's in the
like
packet.
the price concessions, we only have the price concessions for
Data call.
subject drugs. Yeah. And maybe again, for the next iteration, it would be great to get the data call for the subject drug and all therapeutic alternatives, but that's for down the road.
Oh yeah, that's probably a much broader discussion, but I hear
Yeah,
I hear what you're saying. That would enhance all of this greatly, right?
I think so.
And for staff note taking, can you just help make sure that we keep that on a parking lot that we've talked about as a board for the future?
It is. It's the intention for this next go around. So I'm hoping to get the preliminary list shown to the board. With the extension, it's going to be we'll find a way to get all the new data that we just got in for 2024 preliminary list and finish these up. So
One piece of feedback I would have is if we cannot do, for future packets what Dr. Hartung has suggested, I wouldn't be personally a fan of removing that section. But Mr. Lemon, I see your hand is raised, so you have the floor.
Yeah, Dan, I just have a question for you. So if I'm thinking about the scoring, I guess, matrix or table, and we're taking therapeutic alternatives and trying to weave it into price evaluation or enrollee burden, et cetera. I mean, how does that affect the sort of, and I'm not even talking about the numbers that are in the cells. Like, how would I think about price concessions? Is it compared to the therapeutic alternatives instead of it standing alone, I guess? Is that what you're saying? So then you're just comparing the drug to the therapeutic alternative and price concessions, or not price concessions, that's a bad example. Price evaluation or access, whatever it is.
Yeah,
I'm struggling with the concept of how I weave therapeutic alternatives into but like based on what you described.
Well, just for prior conversations, I just want to remind the board that we are to look at the drugs kind of individually and not in comparison to other drugs. If you recall, we've kind of had some feedback on, even though the therapeutic alternatives are a great kind of mark to see what else is going on in the market with similar class drugs, to actually compare a drug, a subject drug, to a therapeutic alternative has been discussed to not be an option. Just because it is the requirement that the board needs to review the drug on its own merit for cost impact. The therapeutic alternatives and equivalents and biosims can give some guidance to the board members for review, but it shouldn't be the decision-making component. The only reason why we updated the packets to kind of show what we have for the therapeutic alternatives is just to see what else is going on in the market, not as the benchmark for each drug. So I hear what you're saying, Dan, is like, trying to incorporate it all, but we have to also make sure we're staying within the line of the statute, that we review the drug that may create affordability challenges and not also engage in possible access issues or anything like that. And John Murray, I see your hands raised.
Thank you. Yeah, I'm not for removing the domain of therapeutic alternatives. It's just difficult for me to wrap my head around clinical aspects of this category. But I still, for example, want to know if marketplace games with patents are happening. For example, if a drug is off patent or should have been off patent, but we keep seeing additional patents extended, to me, that's a game to keep a generic off the market, which affects affordability, in my opinion. So that I do want to see that. I want to know if a drug has been off patent for 20 years and or 25 years, and there's no generics still. So anyway.
So is that a domain that you want added in here, John? Is like patent expiration and then a range?
It does. It makes a difference to me, actually. Okay. Yeah, it does. When does patient affordability come into thinking for generic development or biosimilar development or biosimilar patents that end up with the same drug having different costs throughout the system?
Okay. I have to think about how those timelines would work. Dr. Hartung, I see your hand up.
Yeah, I just wanted to respond to two comments, I guess. Yeah. One, to respond to this issue about the therapeutic alternatives. And yeah, so that's a very good point, Courtney. Yeah, you're right. Maybe we don't want to increase the temptation to do these comparisons across in a category. So maybe keeping it just as number of alternatives in that category. And again, what these cut points are, I don't know. You get into some hairy and gnarly topics here in terms of like equally more effective alternatives. That becomes difficult. So maybe we're going to keep this really high level about just alternatives in the category. And maybe listing them out, I guess, too. About the patent thing, I really agree with that. And I actually have a note from my notes in looking at this earlier. It's almost like a contextual, like a contextual part where we have information about expected generics on the market and or biosimilars on the market for the drug. Like if something's coming out, if something's like going to be brought to market by a generic firm, and it may not be patent expiration because sometimes the patents are expired, but the companies don't want to bring them to market because they're going to get sued. So there's stuff about going through the court system that may prevent generics from coming to the market. I think that some sort of narrative about when do analysts expect generic to emerge, if there's something that's coming out in the next 6 months, then I think that changes the thinking about affordability challenges if this drug is going to open up in terms of generic availability, as John mentioned, or if something's going to be just held up in the courts forever. Then I think there's more serious issues at play with affordability. In addition to that, I think a contextual feature around if these drugs are on the Medicare negotiation list and if it has gone through that process, and like what is Medicare's maximum fair price that they've settled on, or negotiated price that they've settled on, I think would be helpful contextual information to be added to this. Not, again, I would put all of this under the domain of like the larger context for this particular drug.
Okay.
One thing we have to keep in mind related to MFP is that like drugs that have been announced for 2027 are for 2027 prices, not like the look back years that we're looking at. Same with like the 2026 ones. I agree with Dr. Hartung fully. I just wanted to make that comment. And Courtney, I want to have this discussion. I do want to be mindful of all the drugs we have a lot of work to go through today. How much more time do you believe as staff we can allocate to this discussion while maintaining the integrity of time for our drugs?
It's kind of up to the board, honestly. It's if you feel that the domains are kind of set up, I can work with board members over the next couple of weeks for like maybe some scoring insight. I do ask if I send you a email to please be responsive to it so that I can get this set up in a timely manner so that it can be implemented for the reviews in some capacity as a meaningful tool. But
and again, sorry, it wasn't my intention to just stop the dialogue. I just want to do a check related to it. So if we still have rich comments that we want to discuss here, it is an important time. But
again, it's kind of up to the board if you feel that these additional domains kind of meets the intention of the additional review, or if there's any other subjects that the board would like to have incorporated. We don't have to necessarily fill out the scoring capacity. Again, I can work with board members offline. I just want to make sure if we're going to add domains that we're capturing it now, so that next month we can just do a high level review of any additions that were added and then continue with the review of the drugs.
This is John. I don't need any additional domains. These cover my concerns.
Okay.
Dan and John or group, is patent expirations and the Medicare fair price their own domains, or is there a way? I mean, I don't know that they fit into any other domain necessarily, but is there a bigger picture domain that kind of addresses those things?
Not really in the packets. In fact, we'd probably have to add in this information to the packets, which we can. We'll just do it in the summary sheet, just indicating if it has a patent expiration and then what the MFP year is, if it has one. So those are easy ones to add in. But I don't think there's anything that really ties into the rest of them meaningfully, I should say. Dr. Hartung, I see your hand up.
Yeah, I'm often, some of these are like, most of these domains are like kind of, I would say, data-driven domains. They're basically like just collating the data that the APAC or carrier data that we already have, it's already analyzed into specific, kind of organizing it, which is great actually, because when I go through these packets, I kind of do that myself, trying to like pull out the specific most information from each packet. So, but some of these like patent expirations, MFP, even the equity stuff, it's like, it's not internal data driven stuff. So I feel like it's kind of, they fall into like this contextual domain of like, where it's kind of derived from other sources. And so I'm wondering, maybe we want to put them into their own, like just kind of a narrative thing and say, okay, there's a lot of issues with health equity and disparities in this, for this drug. Medicare has negotiated a price. Here's what Medicare's price is. And then, we don't expect generics in the imminent future, kind of that summary statement or something like that. So it's not so much like a quantifiable, something to quantify, but it's like this landscape context thing that we can put all the other data stuff into, think about as we're going through the more data driven pieces.
Okay, let me think about kind of how that would look and set it up. And again, I'll be in communication with y'all in the next week or so for additional feedback, if that works.
And then we're not like trying to like wrestle with, okay, no impact is the next 6 months, high impact is the next 2 years or whatever. That's really hard.
All right. Dan Kennedy, I see your hand up.
Yeah, I just wanted to state that I'm satisfied with these categories. I think this provides all the information. And I think we talked a little bit yesterday about patent expiration. I think the idea behind patent expiration is if something is going off patent in January 2026, it might be looked at differently than something that's going off 2036 or something. So otherwise, I'm satisfied with the criteria here.
Well, I will work to finesse that up a little bit. And again, we'll be reaching out to board members for additional feedback. And I guess if there's nothing else, Chair Bailey, I will send it back to you.
Thank you. The only thing I just wanted to reinforce for the record is that it's my understanding that it's the will of the board that we are refining this rubric, that we may use it in our own personal decision-making processes, but this is not a standalone tool that will be used for decision-making. It is something that we will continue to edit and help guide us in our own personal decision-making, but it does not mean that this is a rubric that will be used as the standalone point of information for decision-making purposes. I believe that is the will of the board, and I want to make sure to reinforce that as we move forward throughout the year and beyond. So with that said, the next portion of our agenda is related to the drugs in our packet. The first drug that's listed in our packet is Trelegy, and it is an anti-asthmatic and bronchodilator. We have 3 public comment letters that we received. First letter we received, in no particular order, was from Harmeet Dillon from GSK, from Linda Nelson, the Oregon Coalition for Affordable Prescriptions, and from Molly Burrich from GSK. We did have one speaker signed up today related to the Trelegy packet, and that is Tom Corbidge. Tom, if you are here, welcome, and you have the floor.
Thank you, Chair Bailey. Let me put myself on camera. Thank you.
Welcome.
Thank you, Chair Bailey. Good morning, board members. I'm Tom Corbidge, a medical director at GSK. And for 30 years, I have taken care of patients with asthma and COPD as a pulmonologist and also a professor at Northwestern University. As you know, these are really common diseases. About 11% of Oregonians have asthma and 6% have COPD. And these diseases can greatly impact patients, and many live in fear of having exacerbations that can lead to hospitalizations and progressive disease. Inhaled medications are foundational to treatment. And according to the GINA guidelines for asthma and the GOLD guidelines for COPD, When multiple drugs are needed, they should be delivered by a single inhaler to improve adherence. Trelegy stands out as the only medication for asthma and COPD that delivers 3 medications in a single inhaler, requiring only 1 inhalation once daily. Trelegy simplifies treatment for appropriate patients, which improves adherence to contribute to meaningful downstream cost savings by reducing ED visits, hospitalizations, and overall healthcare utilization. Oregon-specific analyses reinforce the immense cost effectiveness and real-world benefit of Trelegy. For example, 2023 Oregon PDAB aggregated carrier data showed that the annual net spend of Trelegy was $627,000, just above that, which ranked 125th out of the 158 drugs. GSK is committed to expanding access to Trelegy by offering financial assistance that reduces out-of-pocket costs to $35 or less, and GSK provides substantial discounts and rebates. As APAC and NDC data show, the cost to patients is actually relatively low. The 2024 WAC unit price was only $10.96. Of note, claims data make it falsely appear more costly because these medications come in packets of 28 and 60 units. About 82% of paid Trelegy prescriptions cost less than $50 a month, and about 58% of patients pay less than $30 a month. And the out-of-pocket for Medicaid is 0. Regarding Medicare, Trelegy is already significantly discounted, but CMS selected Trelegy as a 2027 drug for a price negotiation based on high utilization. As such, Oregon Medicare patients may benefit from reduced out-of-pocket if a maximum fair price is established. For these reasons, we respectfully ask the board to find Trelegy affordable for Oregon residents and to ensure continued broad access and uptake. Thank you very much.
Thank you for being here today and for providing this information. Mr. Corbett, if you are able to stay here with host privileges, I would like to A, thank you for being here today, but B, provide some time and space for my colleagues here to ask any questions that they may have of you, both from the letters your organization provided as well as from your testimony provided today. So with that said, do any of my colleagues here today have any information related to Trelegy in general from a clinical perspective, information or questions that cannot be answered for us today within the content of our drug meeting packets? I just want to reinforce, I am not a clinician, so my level of expertise here for you today is probably a bit more limited, but I would again like to lean into my peers who are clinicians and see if there's any additional questions that we may be able to make, since we do have a representative from the organization here today.
Thank you.
So while I kind of scan through Zoom here and I don't see any raised hands from my peers, I do just want to thank you for being here today and for the information that you provided, both orally via Zoom as well as the information provided in the written information that we receive. Thank you again for your time.
Thank you, Chair Bailey. Thank you, board.
Absolutely. So Courtney, you do now have the floor to help guide us through our discussion related to Trelegy.
I'm just going to share screen, but going to lean into board members to provide most of the dialogue and discussion for today. As it is my understanding, everybody has reviewed the packets. And again, I know there's been some updates from the prior packet from last month, basically just indicating more upfront what the therapeutic alternatives are and some of the comparisons with pricing to those. Is there any area that the board would like to focus on for a board discussion? I'm happy to go to that area. Sorry, Chair Bailey, I see your hand up.
Courtney, this is more an administrative thing, but I do want to announce, because I neglected to announce it previously, that it is my intention for us to take a break at 10:30 a.m. Pacific. So we will have a 5-minute break as long as it's in alignment kind of with our discussion. It may be modified a bit if we're in comprehensive discussion on another drug, but around that approximate time frame, it is my intention for us to have a 5-minute break.
All right, thanks, Chair Bailey. Appreciate that. All right, so back to board. As you've all reviewed the material packets for Trelegy, first couple of pages is the high-level summary of the drug and potential impact to the payer system and enrollees, or is there any specific section of the material that you'd like to discuss as a board? And I don't know if this would be helpful to maybe go back to some of the questions that were asked originally in this section. Apologies. I know we haven't finalized some of this process, but in each of the domains, they do have applied questions that might help facilitate conversation.
And I do want to acknowledge Dr. Hartung has his hand raised. So Dr. Hartung, you have the floor.
Yeah, can you hear me?
Yeah.
Okay, my headphones went out. So on the Trelegy one, page 8, we have the changes in WAC, and it says per 30-day supply, but that can't be a 30-day WAC for a 30-day supply.
And what
Must be
then how do you, is there something that we need to go back and reevaluate? Because PayPal does.
Well, I guess I'm just asking, anyone any other board member for $10, $11 for a
It must
30-day
be
supply.
per unit, right? So how many units?
So I guess
Right.
that must be a little error, I guess, or typo.
Yeah, because
Let
the
me on pay, if can you please come on camera and help clarify how this was calculated for the board members?
I'm betting this is a per unit cost and it needs to be equated to package size and monthly dispensing quantities.
Yeah, and Melissa, does pay have co-host?
Yes, I just gave Pay the co-host privileges. So mic and camera should work now, Pay.
And while pay is getting set up for the pharmacists and physicians here, I mean, I read that is it daily dosing? So is it 1 unit a day? Is it 2 units a day? For the pharmacists here, do you have visibility on? I mean, I'm also searching. I did not catch that per unit.
It's once a day, I believe. I need to verify that, but
I'm
Oh,
assuming
I think that's right, Dan.
may take multiple units a day, or
so $300 about.
yeah, okay. One actuation is 1 unit.
Yes.
Okay. Okay. Didn't.
Yeah, so.
I think you're in a different section, Courtney.
It's just showing that. I was trying to.
Yeah, but you're in a different drug. I think you're in the Eliquis.
Yeah, let me go back up here. And hey, if you can hear me, can you please come on camera?
So while we're waiting for pay, I mean, I do see that she says in the packet, it does say units. So if the pharmacists here are saying that the units, it's, 1 dose.
I think it's still a little further up, Courtney. Sorry.
It's okay.
I checked the package insert. It's 1 per day.
Okay.
So if it's per unit, which it probably is, that's like around $300.
Right.
That would make sense.
Yeah.
And
okay.
it says per unit, I think a little bit, like I think I remember reading that in there somewhere, Dan.
Oh, okay.
The first line of price history per unit at the end of 24.
All right, I'm not sure what's going on with Pay, but we'll come back to answering that question. There she is. Hey, Pay.
Hello, sorry, my Zoom isn't working so well on my new laptop. Could the question be repeated?
Yeah, so with my screen, it says that the WAC 30-day summary of these prices, is this unit price or is this package price?
It's unit price.
All right. Oh, it is. It says right here, unit WAC price.
I would say as feedback for the future, because you can't bust these packet, these units, it would be more helpful to see that as a package size.
And the table title Pay is very confusing because it says WAC summary per 30-day supply.
Mm-hmm.
Okay.
So we will update those. All right.
It doesn't affect the actual average annual change, but it's helpful to, again, this is like the list price of the drug, and I think that's helpful to know.
Yeah. So that can be updated for future reviews. This is kind of the nice thing about having rolling packets. Was there anything else, Dr. Hartung, that you wanted to kind of point out?
This is very helpful to have the comparison here. What would be even more helpful actually would be you have it in the graphs below in terms of the CPI, but you could actually just put the CPI data into that table. And so you could compare, CPI is probably running high. It's been running high in the last 5 years. So, but you could put it all in that table. So you'd have the average annual change for the drug, the comparison, and for CPI.
Okay. We can do that for sure. Was there anything else in this section that would help kind of determine or help with your decision making? And is there anything in this section that we should consider adding into the rubric?
I mean, it would get to me, well, maybe not to the rubric, but when we look at this and we look at the other drug that we're looking at, it seems to me that the alternative drug in the therapeutic class is two puffs twice a day. So I think we would be attempting to, and because these units, I want to make sure these units are apples to apples. So like, I'd have to figure out how many units are used in a monthly dosing of the Bertizri, right, to compare. But Mr. Hartung, or your hand's raised, so maybe.
Well, I think we need to have like a 30-day supply comparisons.
Correct. I've been out of the field a couple years now, so my knowledge is getting old. But I mean, I was trying to calculate how many units so we could do a little more of a side to side comparison, even though we're only looking at the affordability of that one drug. These other drugs in the class, that visibility still helps us when we're making these decisions.
Yeah. And then this is based off of the FDA label, so it is two
but it's not the units. Dr. Hartung?
One question for the board about, we have this section here on that, and there was also something you mentioned, the rubric about the pharmacy acquisition costs analysis. And I really, it's in there in the packets, and I kind of skip over it basically because I feel like it's just repetitive with the WAC. So I don't know if that's how helpful that is for people, or like what we're supposed to. In the rubric, there was a statement about diverging prices with WAC and the um, actual acquisition costs. And I'm just curious what people, I don't know if that adds value for me. And so I wanted to see what other board members do with that information.
I think it's in the other one, Courtney. It was under the key questions.
Oh, yeah. And again, those are just developed to kind of give concept, but
It's under, yeah, price concessions. I think, oh no, maybe it's not it's price evaluation, the second question, yeah.
Are pharmacy acquisition costs or net costs diverging from WAC? And I don't have additional input on that. I'm sorry, I don't know.
okay. And again, if that's not meaningful, so that, we can remove that question and apply some other evaluation. As I was going through the material packet, I was just trying to capture what I was seeing. So Dr. Hartung, it's back to you. I don't feel like your question has been answered. Do you not find that the AAAC is meaningful enough to keep in the packet? Is that something that you want to have considered?
I mean, in my own opinion, based on being highly involved in AAAC way back in 2011, I think it's a meaningful data point because it shows a reflection of, at least on the buy side, what pharmacies are paying for the drug. And it's a published number, it's this essentially the state NADAC. So I think it's meaningful to leave in my opinion.
Okay.
Because if there's some big disconnect between AAAC and other pricing, I mean, it could create an access issue if pharmacies can't buy drugs at a price near what a payer would pay. So I would certainly want to leave it in my opinion, but Mr. Murray, your hand is raised and you have the floor.
Yeah, I would agree with you, Chair Bailey, that leaving it in is probably important. I had to think about the meaning of that, or where that question was trying to drill into, and your points are well made. I think it should be left in there. Plus, it's one subjective number that we can apply, and sometimes we have a difficult time teasing out data points, and this is one that's not difficult to ascertain.
Okay. Do you feel that that question in the question sheet needs to reflect the information better, or?
Well, so I'm fine leaving it included and whatnot. Maybe it could be integrated with the WAC analysis a little bit more seamlessly, so we can kind of compare. So I think the AAC was like 1050 or whatever in 2025, which is pretty close to the WAC, 1051 per unit. So maybe even like put it into that table of the first table, so we can actually see if this notion of the difference between WAC and AAC, or look at them side by side.
Yeah.
They look pretty similar, is what I'm getting at.
All right.
But I would need to look at I need to think a little bit more about what AAC. I know it's like the survey of pharmacies and what they're actually purchasing the drug for. But the disconnect between WAC I'm a little bit fuzzy on.
So we may not have that AAAC for the therapeutic alternatives, but we're definitely happy to at least put that stuff in the graph up.
I will say, I don't know how much work it is, but they are published numbers that Myers and Stauffer's provides.
It is, but it is quite a bit of work because each one is in a PDF that we have to put into our data. We have to go into every single quarter, every single month kind of thing, or every single week, and then figure out. So I think for maybe the next iteration of reviews, you can fine tune that process. But I think for the interest of some of the stuff we have, may be time consuming at this point. But we will look into what the possibilities are.
I hear what you're saying. I mean, since they have been a vendor partner for PDAB in the past, hopefully they could also maybe facilitate making the accessibility of it a little bit easier. you know, instead of downloading PDFs of it, but that's just something I was thinking of.
We'll have to see if we can do that, because most of it we just pull off of the published site. We don't contract, we don't have a request for information for them. So, but again, something we can possibly look into. So regarding those, we can this section, I think we have a pretty good path forward. Is there any other sections that the board would like to have a discussion on to help facilitate decision making or additional conversation for this drug? Yes, Chris, I see your hand up.
Courtney, is there, I mean, it was very similar in each of the reviews, but is there a different way to look at equity that's specific to the state or our, you know, community in Oregon?
We don't have any specific data points directed to the drug. We didn't collect that out of APAC, and it is the intention to collect it more thoroughly for next iteration, but there's some, and again, Pay or Heather, since you are the data gurus on this, if you can jump on and clarify any of these questions for the board, why some of the information. But basically, we don't get the information readily available out of APAC. We have to request it. Sometimes it's very sensitive because it's down to like one person in a county or something like that. So we have to be very mindful of possible identification. But it is the intention to hopefully be able to find a process to incorporate more of that Oregon-based stuff.
So when we're looking at the sort of the table that we've, you know, tentatively talked about using to inform decisions, like how would we describe minor disparities or significant disparities? Like how would I or us as a board use that scoring system if they're going to be pretty similar statements, I guess, around equity in each of the packets?
Yeah, so that's why when I do the write-up to try to grab information that is meaningful to kind of capture that, but again, there's not very much information that's Oregon specific without us having to request the additional information. And I see Heather just jumped on. Maybe she can provide some clarification of why we don't have the equity component as a data marker.
Well, basically what you were saying earlier, Courtney, is we do have to request specific data points. We can't just access their database at will. So with these particular things, if there's a specific thing that you're looking for that you're not seeing, then we can take a moment to check that again. But for right now, this is represented based on what we were able to pull and synthesize from what we had in the time frame that we were available to do that.
Okay, thanks, Heather.
Thanks, Heather. I appreciate the clarification. And John Murray, I see your hands up.
Oh, sorry, I'm getting multiple bits of information here. Just one thing, I'm still on the cost of the inhaler, and I'm asking the pharmacy now about Trelegy billing for a claim and the package cost versus the unit cost, because I just need to, when we bill a Trelegy, we have to bill a quantity of 60, not a quantity of 30, which is just because there's only 30 that have active ingredient in it. So I'm still working to tease that out. I want to know, and maybe the GSK rep, Mr. Corbridge, could answer that question more quickly. Is it 30 times the figure in the column, or is it 60 to get an you know, a WAC figure or near the WAC figure? How is that calculated? So I'm working on that. But my question that I raised my hand on was about enrollee burden and some of the comments that were made to us about calculating the enrollee burden so that it's as accurate as it can be. And there was comments about including multiple assistants, or I don't, there's so many acronyms in pharmacy, I'm losing track of them here in this discussion, but copay assistance of one kind or another, or actual out-of-pocket for the patient, are we duplicating and throwing off our calculation of what is actual out-of-pocket? I guess is kind of what my question is.
Are you referring to this section of the material packet? Where's the out of pocket?
Yeah, I am. Yes. When it comes down to an individual enrollee, yes. There were comments made about we included multiple columns or something, and I just want clarification on that, so that I understand it better.
You're specifically asking about the total out of pocket in the table here, correct?
Yeah.
Okay.
Right.
So yes, the coinsurance, copay, and deductibles are sum totaled, and any other associated costs that were reported through the data call were sum totaled to create the out-of-pocket cost. And so that would be the total represented for that market, in this case, the very top number for the individual market for that drug.
Okay.
Did that answer your whole question?
Yeah, it helped. Thank you.
Yeah, so this is the total, but then this is the like average out of pocket. Is it per fill, right, Heather?
This is for, so the out of pocket based on the number of enrollees reported for that drug. So per enrollee or divided by the number of enrollees.
This would be a yearly.
For the year.
Yes, yes.
Yes, okay, thank you.
And I will say back to your Trelegy comment, John, and the active ingredients in the units billed, based on WAC of Trelegy, to me, when we go up and look at the $10 a unit, I mean, that's billing 60 units.
Exactly, and that's it's tricky because
it's 60 units, and so we have to look at that, you know, we have to multiply the Trelegy ellipta by 60. So that is the actual drug versus therapeutic alternative based on WAC and a 30-day supply would be the 2024 number of 1094 times 60.
Yeah, our AAC for the medication.
650, 640. And then what we don't have the clarity on is I think that's 4 puffs a day of the alternative drug. But thank you for checking with your pharmacy staff on how they're billing it, but related to units. And so moving forward on anything that's like a package size like this, where you dispense it as a full package size, that's where we'll and maybe, you know, us individually working with pay, we're gonna have to help provide some guidance on.
Yeah, unless John, you can provide us with some resources that tell us how the packages are distributed.
Yeah, we're happy to. Yeah.
Something of that nature. All right. Dr. Hartung, I see your hand up.
Oh, I was just going to say, Megan, your clinical person, can help you translate the unit costs into 30-day costs as well.
Okay. Yeah. We can do that as well. Any other sections or feedback of how to view the drug? Otherwise, Chair Bailey, I'm happy to send it back to you for a break if the board needs one.
Absolutely. Yep, my alarm went off a couple minutes ago. So I do want to announce that we're going to have a 5-minute break where we will return to session at 10:40 a.m. Pacific. Welcome back, everyone. Melissa, can you call a brief roll just to ensure that we have quorum before we proceed?
Chair Shelley Bailey.
Present.
Dan Hartung. I'll come back to Dan. Dan Kennedy.
Present.
Chris Lehman, John Murray.
Present.
So we need, oh, Dan Hartung, see you
Present.
there. And Chris Lehman. So we're just waiting for Chris.
I do believe before we proceed, Melissa, we need to wait to confirm Chris is here so that we can ensure that we have quorum.
Okay. We'll keep an eye out for his camera.
And Chair Bailey, you don't have to have quorum to continue, just for voting.
Okay, well then
Decision.
let's go ahead and proceed.
Okay.
So related to proceeding, Courtney, it's my understanding that we, before our break, we essentially ended our discussion on Trelegy for the time being. But if anyone has any additional comments or observations related to the packet or related to the drug itself to continue the discussion, I just want to provide the time and space for us to be able to do that. I do see a hand raised, so Dr. Hartung, your hand is raised, you have the floor. But we cannot hear you.
Yeah, on page 20 of the Trelegy document, looking at cost per enrollee, and presents the total broken out by, so it says Medicaid has been taken out of this, which I think is appropriate given that Medicaid recipients don't pay out-of-pocket costs typically, or they have nominal out-of-pocket costs. It says total Medicare commercial cost per enrollee, and then total, I assume that's basically just everyone, an average of Medicare and commercial for the year. And then it has median and interquartile range, IQR. The average for the year is $391. The median is $30. So that means, so the median is basically half the observations are below that, half are above. So that tells me that there's a lot of people, well, half the people have, I would say, pretty low out-of-pocket costs for the year, if I'm reading that correctly. And so, and I also want to just verify that we're excluding the Medicaid from these totals.
That is correct.
Okay. So we have some people, we have a pretty skewed distribution. We have some people with probably very high out-of-pocket costs, but at least half are only paying $30 out of pocket for the whole year or less.
I suspect that's per month, although the table doesn't say what the time period is. Looking at the WAC of the drug and things, I looked at table 12 and table 13 as per month, even though not identified in the title. Is that an accurate assessment, Heather?
My apologies, my audio
So
wouldn't
these are
turn
out
on.
of pocket. No. I think that would probably not be the accurate assessment then. We would, to your point, Dr. Hartung, we need clarity on if that's
Well, yeah, the table below is per claim.
Yeah.
So.
Correct. So can you reiterate your question, please, Dan?
He's asking if majority of the drugs, the median is at 30, with the average being 391. Is it on a monthly or is it annually?
That is annually for the year for those enrollees for out-of-pocket costs.
Yeah, more specifically, my question was just to verify that. So with a $30 medium, we're saying that at least half of these patients are paying $30 out of pocket or less per year for this drug. And that's the correct interpretation of that, right?
Yes.
Okay. And that we're sure that we've excluded Medicaid, because if it was Medicaid, then yeah, there'll be a lot of people with zeros. So these are all
Yes.
Medicare and commercial in there.
Yes.
Okay.
Is there anything else, Dr. Hartung? That's a good call out.
Well, it just I just found it interesting that there's this, you know, I guess it's not surprising. There's always skew in healthcare data. That's just how it works. There's a high, you know, a small number of people who use a lot of services and a lot of drugs and things like that. And so there may be just people who have very little utilization, and then some people with a lot of utilization. That's kind of mixed, that's blended into this average for the whole year.
I guess the other thing I was thinking about related to that is that a big component of that would be plan design, right? That some payers may be still covering it, but it's not tier 1. So you have a lot higher out of pocket for some, but then some it's preferred and they have a $5. We're going back to the data on what their average copay was, right? But I do think moving forward, like table 12, if it said per therapeutic alternatives and out of pocket cost per enrollee per year would be helpful.
Yeah, we can get that updated. Show that it's annual. Okay. Is there anything else on Trelegy board before moving down to Eliquis? All right, hearing none. My system is not happy today.
Well, it gives everyone a couple more minutes to think. So
Okay.
not necessarily a poor thing.
All right. So starting with.
So related to Xarelto, Courtney, I would like to make a few announcements related, or excuse me, Eliquis. I would like to make a few announcements before we proceed with the packet. So related to Eliquis, we did receive public comment. We received 8 letters. Those letters are from Anne Marie with Bristol Myers Squibb. We received 3 letters. From Sarah Hoffman, Partnership to Advance Cardiovascular Health. Sue Cope from Prevention of Cardiovascular Nurses Association. Carla Pirch Marston, family caregiver, James Grossel, John Mullen, and board members of the Oregon Coalition for Affordable Prescriptions. In the past, we've had speakers Anne Marie from Bristol Myers Squibb spoke at the July 16th board meeting. We do have an individual, Jessica McBride from OCAP, who would like to speak to the board today. So Jessica, if you are here, welcome, and you have the floor.
Hello. And just to clarify, my comment was originally intended for general public comment, but I'm happy to speak now.
Oh, okay. I did receive communication from staff, so thank you for the clarification. You have an additional 12 seconds, but welcome.
Awesome. Thank you for the opportunity to comment today and for the time and effort that you have all committed. My name is Jessica McBride, and I am from the Oregon Coalition for Affordable Prescriptions, or OCAP. OCAP represents Oregonians from every corner of the state in all walks of life who struggle with the high cost of prescription drugs. We do not partner, nor do we receive funding from pharmaceutical companies or pharmacy benefit managers. Every person deserves access to affordable prescription medication if they need it. And the healthcare system, especially with regard to prescription drugs, is not working for Oregonians. More and more of our seniors, families, neighbors, and communities are suffering, while pharmaceutical companies continue to bring in record profits. For example, the makers of Eliquis, which nearly 1 in every 100 Oregonians filed a prescription for in 2023, have extended their patent and added follow-ons. And according to revenue statements and consensus estimates from Wall Street analysts, Bristol Myers Squibb and Pfizer are expected to collect at least $50 billion in U.S. revenue from sales of Eliquis, which otherwise would have had to compete with a generic version originally approved by the FDA in 2019 for a 2022 launch if it wasn't for these extensions and add-ons. We're here to say that it doesn't have to be this way. We can build a world where accessing a life-saving medication doesn't cost people their life savings. And your work on the board can be an important step towards this reality. It takes courage to implement something new, especially if that something presents a threat to wealthy and powerful corporations. Each month, you are presented with numerous comments that are rooted in a vague and misleading definition of the Oregon PDAB's authority rather than in the specifics of Oregon law. This definition conveniently fits into pharmaceutical corporations' narrative that any reform will reduce innovation and access, even as that has been proven false across the globe. For too many Oregon patients, these meetings are inaccessible due to timing, jargon-filled conversations, or even just a lack of awareness that anyone is doing this work. Comments from pharmaceutical companies and advocacy groups that receive pharmaceutical company funding outnumber patients and independent advocates. And affordability reviews continue to be delayed and timelines are extended. Your mission as a board is to protect Oregonians and our healthcare system from the high cost of prescription drugs. As you move forward with affordability reviews, we urge you to keep this mission and Oregon patients as your North Star. Act boldly and decisively. Do not allow the pursuit of a perfect process to overshadow your mission. Thank you.
Thank you for your time and for your flexibility in being this portion of the agenda. So Courtney, back to you related to our discussion on Eliquis.
All right, thank you, Chair Bailey. Let me get my screen back up. All right, starting back with Eliquis. Again, identified with 3 therapeutic alternatives. High-level information for the summary page. Is there any sections that the board members would like to start with or have clarified or help facilitate the conversation to determine if there's a cost impact? And I do understand there's some updates that will need to be incorporated for the next reviewer to improve the packets. But yeah, Chair Bailey, I see your hand up.
Mainly, I was just going to say that if anyone has any feedback, related to some of the things that came up in our Trelegy discussion, we could discuss that. Otherwise, also going back to the rubric that had some questions on it, I think that was a really good way to help facilitate some of our discussion related to Trelegy.
So again, kind of starting here with the 30-day supply for the drug versus the therapeutic alternatives over the year. Is there any questions for board that need clarified? Dr. Hartung?
I don't suppose we have any sort of insight into the price drop of Pradaxa over this period, which is pretty striking.
I do not have any. Let me ask Kay, when you were doing the analysis, did you see any indication of why there would be a significant price drop from 2022 to 2023?
No, I didn't. I don't really know why. It was the WAC just dropped in Metaspan.
All right, thanks, Faye. Any Dan, we can look into that just to see if there's any literature on why it is, but if that would be helpful to you for review.
Well, it's striking. You don't typically see things like that. So it's something that you would maybe probe a little bit. It's not critical, but again, it's unusual.
Understood. Again, I was going to kind of scroll through, see if there's any other comments, feedback, or conversations the board would like to have. Or if you would like me to jump over to the question page. So
Wait, I'm sorry, can you scroll back up to that figure again?
what one?
Where you, the one with the WAC changes over time. That one, that one here. So are you saying that Eliquis changed? Oh, I suppose it's 6% per year is what it was it going up?
Yeah, so and again, hey, if you want to come back on and answer Dr. Hartung's question regarding the WAC percent change for Eliquis and how it associates with the CPIs.
Yeah, so it would mean that Eliquis changed approximately about 6% every year. And then these are also percentage changes for CPI. So, for example, from 2018 to 2019, the CPI universal would have increased about 2% over those years.
Okay. Is that what it actually changed every year, or is that because I know the average over the time period was 6%?
Yeah, that's actually what it changed.
Okay, so every year they increase the price 6%.
Mm-hmm.
Okay.
Yeah.
Thank you.
Of course.
Alright. Any other comments or questions from board members?
Courtney, can I ask a question about the table on, or number, page 4? It's that total expenditure or out-of-pocket cost that Dan had brought up previously. I hadn't thought about it in the way that it was explained, I guess, in, oh, sorry, it's the,
It's my computer. I have too many programs open, so it jumps around a lot.
okay. Okay, so in that second table that's down there, to Dan's point earlier, the median cost per, and this is per year in the cost to enrollee section, is $70. So half of the people are paying less than $70 for the Eliquis prescription, but the 602 is what, the average, like the mean cost? So there's actually a lot of people paying more than $602. Is that how I'm supposed to understand that?
Yeah,
The 602 is basically just taking the out-of-pocket cost and dividing
it by the total
the
number of
number
claims.
of enrollees. Yes.
And that's per year, right?
Yeah.
So
Yes.
was that all you had, Chris?
Yeah, that was, I'm just making sure I understand that.
Yeah. Dr. Hartung.
Well, I'm wondering if there's a way that we want to break this down, because this one in particular, there's so many people taking Eliquis. It is a very heavily used drug that, you know, this is a blending, as Chair Bailey said, of planned inputs as well as utilization chain differences. Like some people may only have 1 or 2 months fill. Some people are on it for the full year. So we're getting this blending of all these different factors. And so I'm wondering if we want a little bit more nuance in how the data are displayed in terms of, like, you know, people in the 75th percentile or whatever, which still could be a lot of people who have to pay, who are paying, you know, who are filling it every month for a year because they've been on it for a year, versus someone who just started in December or whatever. It's kind of, you're mixing those people to get those two types of people together. So I'm wondering if we want a more more summary of the description of the breakdown and distribution of these types of patients, like, you know, 75th percentile or 90th percentile or something like that, along with the number of people in those different buckets. So we can kind of understand, you know, the heaviest utilizers are maybe heavily impacted by out-of-pocket costs.
I will have to lean into Heather if we have that level of months the drug was filled. I don't, maybe.
Not at this time, we do not. But I can look into that a little deeper to see if there is a way to do that. But I don't have that readily available.
Well, I don't think we need to get into like how many months the patients were taking it, but just like breaking, you have the median here. If you could do the, you know, the 75th percentile, 50th and 25th percentile of out-of-pocket costs, and then the number of people who fill in those buckets.
Okay, I will,
Just
getting the percentile, yes. Determining the people will take a little bit more time to consider, but yes.
All right. Any other suggestions or updates? Was there any other section that the board feels that they would like to discuss or have a conversation about as a board?
I think it was really impactful for me, Courtney, to look at the patient comments on this one. I mean, there were so many comments about ordering the drugs from Canada and how impactful the costs are for a medication that's, I mean, you know, life-saving for so many people. So that was very impactful for me just reading in the packet.
Yeah, those all came from the survey response. And then again, if any surveys come in, then we just update the material packet with the new comments as well. But glad that was helpful. And apologies for the scrolling. Dr. Hartung, I see your hand. Oh, when you're on mute.
One comment on the monetary price concession section. Sorry to be flipping back and forth. Page 11 or 12. It would be helpful if we have it framed as the percentage of cost remaining after concessions, which I think is a little reverse of the way I like to think about it, in terms of the percent, like the discount basically. You know, 68.9% of cost remains after concession, which means like the rebate or the concession or discount is 31.1%. So it would be helpful if it was just framed that way versus the cost remaining.
Okay.
That's the way I kind of think, like 30% rebate or 50% rebate.
That's a good recommendation. Heather, did you note that to do your update?
It did.
Yeah.
I agree with Dr. Hartung that that's how I think of it, is what is the percent off.
Okay. Will do. Anyone else for comments, feedback, or discussion? Otherwise, we can move on to Xarelto.
I mean, one just thing I noticed, Dr. Hartung, back to your point about the drug price inflation, you know, the 6% steady year over year is the max related to Medicare IRA. So I just thought that was something that I noticed that piqued my interest, was I saw the max inflation that you could do without the penalties. So it was just an observation of mine.
Well, hearing no more comments, Chair Bailey, I can send it over to you for any comments regarding Xarelto.
Oh, related to Xarelto. That's helpful. I had that on my other sheet of paper. So thank you for providing that information to me. So for everyone here today, we are now going to be reviewing Xarelto as part of our affordability review process. We did receive public comment related to Xarelto. Those letters we received 5, are from Sarah Hoffman at the Partnership to Advance Cardiovascular Health, Michael Valenta from Johnson & Johnson, 3 letters were submitted, from Sue Cope from the Preventative Cardiovascular Nurses Association. We have had a past speaker related to Xarelto specifically, who is Silas Martin from Johnson & Johnson, who spoke at the May 21st, 2025 board meeting. And then the individual that we have signed up today to speak is Lisa Pulver from Johnson & Johnson. So Lisa, if you are here today, welcome, and you have the floor.
Hello, can you hear me okay?
We can hear you. Thank you and welcome.
Thank you so much. Hello, I am Lisa Pulver, Strategic Market Director, Regional Government Accounts at Johnson & Johnson. Thank you for the opportunity to discuss Xarelto. We respectfully ask the board to find Xarelto does not pose affordability challenges based on the following. First, Xarelto should not have been eligible for an affordability review. Xarelto has an FDA generic approved, a reason given today for excluding other drugs. Also, when selecting drugs, Oregon law requires the PDAB to prioritize drugs on 3 top 25 carrier-reported drug lists and 2 Oregon drug price transparency reports. Xarelto only appeared on 1 list and in neither report. The PDAB also agreed to exclude drugs subject to a maximum fair price under the Inflation Reduction Act. Xarelto's MFP goes into effect January 1st, 2026. Therefore, Xarelto is not eligible for a review. Second, Xarelto is affordable for Oregon patients and payers. J&J offers various programs to support patient access to Xarelto. Eligible patients can pay as little as $10 for a 90-day supply of Xarelto through our savings programs. Uninsured or underinsured patients may be eligible to receive these medications at no cost through our patient assistance program. The PDAB's data also demonstrates Xarelto's affordability. Across all payers, on average, patients pay between $0 and $71 per copay, $0 to $51 in coinsurance, and $0 to $110 for their deductible per claim. Xarelto is also affordable for payers. Of the 16 drug products under review, Xarelto falls within the bottom quarter of the list across all payers when sorting the dashboard data by average paid per claim, paid per enrollee, plan spend per claim, and plan spend per enrollee. Instead, it appears that Xarelto was selected solely based on the number of claims and enrollees. Yet, given so many Oregon patients can successfully access Xarelto, actually speaks to its value and affordability. For these reasons, we ask the board to find Xarelto does not create an affordability challenge for Oregon patients or payers. For further detail about these points, please refer to our written comment. Additionally, we have significant concerns with the Xarelto affordability report, which the PDAB just posted last week. We intend to address these concerns with a future comment. We know that patients are counting on us to develop and bring to market accessible medications. We live this mission every day and are humbled by patients who trust us to help them fight their diseases and live healthier lives. Thank you.
Thank you for being here today. And I would ask that Ms. Pulver, if you have the opportunity to remain here while we have our discussion in case any board members have any questions, I think that would be appropriate at this time. So I guess I'll first ask related to the oral comments or any previous testimony or written comments that have been provided related to Xarelto. Do any board members have any questions that they would like to ask now? And if not, I would just say, Ms. Pulver, if you want to stick around during this section, in case any board members do end up having questions that they would like to ask, it would be appropriate for them to ask that of you. So thank you.
Absolutely.
And so Courtney, you have the floor to help guide us through the discussion related to Xarelto. Although you are on mute, just so you know, and I know you're working on your screen.
Yeah, thank you. All right, so starting with Xarelto. Again, high-level summary identified with 3 therapeutic alternatives with an average rate increase of 4.5%. Coming here to the payer information and enrollee information. The board a moment to review that information. And then please let me know if there's any specific section that you would like to go through and discuss, or if there's any information within the first few pages I can scroll back to.
I do think as you're scrolling, Courtney, one thing that does help us have rich discussion are to maybe go back to some of the domains and some of the notes associated with the domains so that it might pique some of our thoughts related to having a rich discussion on Xarelto.
Yeah. So I can go here. Again, just some high level questions. Yes, Dr. Hartung, I see your hands up.
It was mentioned that there's a generic available for Xarelto. I don't know about, I assume that's true, but do we know anything about, is it just one generic? Is it, how many manufacturers are making it?
My understanding, Dr. Hartung, because I did hear that comment and was listening, is that the first generic for Xarelto came out in 2025. So from my own perspective, we were looking at 2023 data.
Is it available, Chair Bailey, or just has been approved to have a generic? I was going to ask that question.
I'll lean into you guys
Lisa.
who are still working the bench every day to let me know that. I just looked at what I could find online. So the pharmacist here will have more real-time information, but at least in my own head, I was still thinking that we are looking at the reference range that our data is from. But related to it being readily available point of sale, some of the pharmacies here might be able to, pharmacists here could provide more real-time information.
Yeah, I don't remember this being available yet, but I'm checking right now.
Yeah, I was gonna go on our order site too, John, to see, but I don't know of us ordering it at a generic at this time.
I'm not finding much information either. Even so, during the drill down of the subset list, it wasn't identified as, so Xarelto still qualifies to be reviewed in any capacity based on the other criteria of the selection for the subset list.
That's an alignment with how I understood the process. So thank you for clarifying that for all of us.
Yeah. Especially since I'm not seeing any market movement with that generic. Just articles that there's a potential one coming to market in 2025, starting back in March. But that's just a quick review. We're not dove any deeper into it. But anyways, at this point, Xarelto still qualifies to be reviewed under the board review criteria. Dr. Harkin? Oh.
Yeah, I mean, I agree we can review it, but I think like this is a good example of like contextual factors. You know, if something is, if it's imminent, you know, we may decide that this is probably not an affordability issue if we have, if there's teeing up at least one one to several generics coming online, I think that would change my decision making about the affordability of this drug. So I'm just pointing that out as like, potentially something to think about as we make our decisions in the future.
Yeah, and I think part of that conversation, Dr. Hartung, is knowing if the generic drug is on market and being distributed versus it just being approved. Just having an approval doesn't mean that it's showing an impact yet for patients, especially out-of-pocket cost to patients.
No, but I mean that's knowable. We can figure that out for the date that we make these decisions. Like, is it out there? Our pharmacy is dispensing it, is available, and then we can kind of have that incorporate that in our decision making process.
Yeah, it's not available on market for my ordering yet.
Thank you, John, for clarifying that at this time. Let's kind of keep an eye on it as we continue to review the materials of these packets.
But leaning into Dr. Hartung's comments a couple hours ago related to drugs that are coming off patent soon, I mean, that was your intention, right? On earlier in our framework, looking at drugs that may have a generic in a relatively short time frame. I'm assuming that's where you were headed with adding that to our rubric.
Yeah, precisely. Like, if at the end of the day, if we go and honestly, we're always going to be behind, our data is going to lag and things like that. It's our process, I think, is for selecting the drugs is good. But the last step where we look at the data and think about the decision about affordability, if we know that there's a generic or generics coming in the next 6 months or fewer, then that affects my decision, my thinking about this of a drug.
Thank you for sharing that. Mr. Kennedy, your hand is raised. Do you have the floor?
Yes, I just wanted to agree with Dr. Hartung. Also, I think we're, in terms of framing this, we're looking at the affordability today, right? Not 2023. So I think knowing whether a generic is available, multi-source or single source, is valuable information.
I do believe we should seek clarity from staff on that, though, because I've always essentially been under the understanding that we're looking at the data from the years that were presented to us. But to your point, when we all vote personally, we could make disclaimers related to the data that we looked at versus what's going on in the market now. But my perspective has always been a little more the data set time period. So staff, if you could clarify that for us, that probably would be helpful.
Yeah, so again, the statute indicates that the drugs under review is from the prior year, but that's just for your base data information coming in. We can look at market impact to see if there has been changes from the previous year. So it's just the statutory language is just to ensure that the review of the drug is from the previous year. And
So all of it's helpful. All of it's helpful in the decision-making process for each board member. Thank you.
Yeah. All right, so appreciate the conversation. Again, board members, any specific section or any additional topics that you would like to have as a board at this time for Xarelto? Again, we're not making or voting on any of the drugs today. This is just review of the packet material, and it is encouraged that the board continue to look at the packet materials as you kind of do your work in determining cost impacts for these drugs.
I mean, a couple call outs I saw, of course, is that both Eliquis and Xarelto are clearly, among some of the top spend, in the state, right? That jumps out to me.
Yes, that's one of the reasons why they were selected.
Well, of course, but I meant even among our subset list is where I was headed related to that.
Dr. Hartung.
This may be somewhat controversial, but the comparison therapies in both Xarelto And Eliquis, we don't include warfarin in it, which is very cheap and still is used. And so it's not obviously not a perfect comparison, but it is a benchmark that's been used for 50 years.
And this is back, Dr. Hartung, to a comment you made in a previous meeting related to the migraine meds, right? You made a comment that, you know, there's obviously other therapies that have been used that didn't show up on our, you know, list of other drugs that we are looking at when we look at the subject drug.
Yeah, these are all the direct acting anticoagulants, the newer ones in the last decade or so. But there are plenty of people who are managed effectively on warfarin for coagulation related disorders and AFib and things like that.
For me, it's when I see warfarin still used, it's usually always a cost factor. So the neediest people that the people that need it, that have no money and no coverage and don't apparently know how to seek assistance from the drug manufacturer, for example, which, by the way, we help them with to the best of our ability. And that's where warfarin comes in. So yes, it's still definitely in play in patients.
So what I'm hearing both of you say is that related to these drugs, the ones we're looking at, there's very much potentially a social determinants of health perspective related to potentially accessibility for some patients.
It's a thorny issue because the drugs are definitely, there's an effectiveness benefit to these drugs and a safety issue to these drugs and an ease of administration for these drugs versus warfarin, which is a little more difficult to use because you have to monitor it so often and has dietary issues and but you know, again, as John noted, people are still taking it. I've even in my own family, my father's on warfarin, my mother's on Eliquis, so even controlled for socioeconomic factors, there's variation in use.
Would it be helpful for us to pull some of the data points for warfarin into
I
this?
think just for context alone.
Okay. Yeah, I just made a note to look into that. All right. Any questions or conversation around health insurance plan, line of business, cost, calculations, or utilization? And again, if the board doesn't have much conversation at this point regarding Xarelto, we can move on to Cosentyx and cover anything in there. Because as I've already stated, these are rolling documents and the board can come back at any time to review any of these drugs and hopefully with some clarification with the rubric and kind of enhancement of the process as we go forward, we'll start pulling out where to start really looking at the impacts. It's just nice to have a review of the packets as a board for these discussions. All right, so hearing no more conversation or questions regarding Xarelto, Chair Bailey, I will hand it back to you to see if there's any public comment for.
Absolutely, thank you. So we are moving to the affordability review for Cosentyx, which is a dermatological agent. We did receive public comment. We received 4 written letters, letters from Courtney Puron from Novartis. 2 letters were received from Gabrielle Draper from Derma Access Care Network, and from Kim Sanders with OHSU. We do have one speaker who is signed up today to speak related to Cosentyx, and that is Tiffany Westrick Roberson from Each Pick Coalition. So I do want to acknowledge that she is here to provide testimony today. So Tiffany, if you are here, welcome, and you do have the floor.
Chair Bailey, Tiffany is here, and I'm having some difficulty making changing your settings, Tiffany. I'm not sure why. I wonder if
I think what we'll do, Melissa, is we will have our discussion, and then I will circle back as we near the end of the Cosentyx discussion, and we will for sure make sure that we you're able to work on it so that we can still hear the comment from Tiffany.
Thank
So you can work on that. We will have our discussion and we will circle back. So Courtney, you have the floor.
Thank you, Chair Bailey. Get my screen shared for everyone. Again, starting with Cosentyx. Six therapeutic alternatives with an average 6.7% rise in price from 2018 to 2024, with each therapeutic alternative rate raising within different percentages. High level. Payer impact versus enrollee impact. Let me know if you have any specific sections that you would like me to jump to, or I'm just going to kind of scroll through and we can kind of facilitate conversation. Dr. Hartung, thank you.
Just kind of referring back to this discussion about the rubric and the domains. I almost think like when we get that finalized, having the executive summary that we have here replaced with kind of like the data summary for the rubric for these, or at least maybe an additional page at the top. So like high level summaries, like here's how this drug is quantified according to these are the critical domains that we're using, would be incredibly helpful for me.
Okay. I'll see how I can incorporate that. Otherwise, I may have to have a touch base with you to help facilitate that concept.
Are you talking about the scoring too then, Dan? If we have it lined out, like within that rubric, this would be classified as a 3, severe impact based on the metric that we've decided on?
No, I was thinking more along the lines of like acts for example, impact, like how many Oregonians take it, have that clearly laid out. Yeah, how many Oregonians, price evaluation, what's the average annual change in price over the last 5 years?
Pulling the answers from the rubric into the executive summary portion.
So not giving a score necessarily, but basically telling you where on that scale it's falling.
Yeah, so if drug falls between a 0 to 99, you can indicate as a 2.9% increase from 4 years. So it's a quick snapshot of where it would reflect in here.
Please.
Is that what you're referring to?
I kind of find myself just pulling out those data points from these reports into a separate document as I go through these things. Anyway, so just having those in a top level thing would be helpful. If this is where we're going to focus in terms of like our decision making.
Yeah, I can work on something like that and mock it for next month's discussion just to show what it would look like. That's a good idea. Thanks, Dan. Appreciate it.
Really helpful idea for each portion of the packets.
Especially since it's broke out per domain. So it's included into the summary via rubric breakout. All right. And again, please board members, if there's any sections that you want to speak about as a board at this time, let me know and I can scroll through that. Otherwise, I'm going to just kind of do a quick scroll to see if anything needs to be a conversation point, and then we can move on to Creon. I appreciate the feedback on how to kind of improve these material packets for your review and eventual decision making of the drugs. And would the board members like me to go over to the questions at all, or we kind of just you good with just reviewing this real quick and then see if there's any facilitated conversations that needs to happen under Creon? And hearing none, I will wrap this up in a second and move over to Creon. And just to point out, majority of the CCO quarterly information was removed out of here because there was many drugs that didn't have the reported information. But if it did show a year-over-year change from the previous year, I did keep that graph in just for reference. That there's also an impact going on in the state system.
I think if you could stop there on page 20, I think something related to these numbers, I guess. So if I'm reading this right, 100% of the plans required a prior authorization on Cosentyx. Is that something that I read that accurately?
Yes.
So if I did, then I mean, from my perspective, I mean that is certainly something when we talk about social determinants of health, access, and barriers. Just wanted to flag that 100% number jumped out at me.
Yeah, so again, if you're looking at here, we have the,
Yeah.
So it is in there to show. And so again, as Dr. Hartung is explaining, if we do this as a in the summary page, this would be pointed out that 100%. So then it would be under the scoring metric.
Oh yeah, no, and that was just an observation for the record. That's all that was that, to me, that's meaningful.
All right, the rest of it is just based off of manufacturer, FDA label information, and clinical review. If the board doesn't have any other comments or discussions for this drug, I can pass it back to you, Chair Bailey, to see if the commenter is ready to provide comments, and then
Well, so I'm going to just make my own personal comment here as I'm going back between my notes on all the drugs. Some of the other drugs we've reviewed, just to share, have required prior authorization of like 36% or something. So when I see something like 100, that is just exceptionally meaningful to me. And I would just like to share with my colleagues on the board here, the OIG put out a report last summer related to how prior authorizations impact access for consumers. And I just want to really lean into when I see something like that, it's just a cause for pause for me personally. So just referencing that, I'll go back and write the exact percents on all these drugs just for my own notes, but that is just something I wanted to share. So like, for example, Trelegy in our packet shows 36% require a prior authorization for that drug. But Mr. Kennedy, your hand is raised and you have the floor.
Yes, I just had a quick question, I think, for Courtney. With 100% of those prescriptions requiring PA, do we have any inclination on what the percentage of denials are? Or do we have any way to figure that out? Or
so that's a Heather question. I'm going to lean into her since she's their data guru.
Based on the information collected in the data call, that is not a number we currently have at this time.
Okay.
And To add to that, Mr. Kennedy, that is something that I've talked to staff about, but I also just want to give staff credit that and carriers that some of that information is a lot more difficult for us to obtain than it might seemingly appear. So I concur with you. That's an important data element, but it has been harder to get, I believe.
Great. Thank you.
So with that said, it does appear that we will be moving on to our section of the agenda related to the drug Creon, which is a digestive aid. We received public comment. We received one letter from Albert Fardo from the Cystic Fibrosis Foundation. We've also had a past speaker related to Creon, which was Lindsay Silva, a mother and primary caregiver of someone living with cystic fibrosis, who spoke to the board on May 21st. And we do not have any speakers signed up for today. So I see on screen that we have Cosentyx, but I believe that we are now speaking
We
about...
needed to go back and speak because Tiffany didn't have her opportunity for public speaking time. So we're going to provide
My
that.
sincere apologies. Thank you for the reminder. Hopefully, Tiffany, we've worked out the technology related issues. My apologies for trying to pass through that. So welcome, Tiffany, and you have the floor.
Right, thank you. And I'd like to clarify my mistake. And when I signed up, I'm not speaking on behalf of each PIC coalition right now. I'm speaking as a patient, a person living with non-radiographic axial spondyloarthritis, and a person who was on Cosentyx for 4 years. My diagnosis is a systemic autoimmune disease that affects my spine, my feet, my hands, my chest, my eyes. I'm actually leaving to go to the emergency room here as soon as I'm done speaking because it also affects your organs. And saying that, like many patients, I've had to cycle through multiple specialty medications to find the one that works because none of us are exactly the same. And I would just also like to point out that it's listed as a dermatology drug, but it is so much more. I was on Cosentyx from 2021 to 24 after my first effective medication stopped working. And before I was on a biologic that actually worked well, which is a big trial and error process. I couldn't get out of bed because my spine felt like it was glass. And the only way to get out was to roll onto the floor on all fours and wait till I could stretch my back to walk again. Cosentyx gave me my life back. I was only forced off of it because insurance decided to non-medically switch me to a therapeutic alternative that they felt would save them cost. I fought prior authorization and trying to get my drug back, where I went without any drugs for 75 days, and in which time I developed neuropathy, and I still to this day cannot feel my feet. This is an example of why it is so dangerous to do cross comparisons of therapeutic alternatives. For people like me, finding the right treatment is the only path to remission, and access should never be compromised. I also wanted to share my story for a couple reasons. One is Oregon decides the fate of Cosentyx and policy recommendations around it. Please remember to set forth policy recommendations that ensure that for no reason any patient is asked to switch to their medication, even if Cosentyx ends up being the least costly, then that means the rest of the people with the same diagnosis risk losing access to their miracle drug. It also is not exactly a therapeutic, that it is an IL-17 inhibitor. The ones that, other than I think one on that list, they all target different mechanisms of action. I also just want to say is personally, those of you who may not know, I'm also the co-chair on the ICER Patient Council. So I'm very versed in health technology assessments and cost effectiveness analysis. I appreciate what's been done with the framework. I look forward to looking at that further. And I just want to point out that this is a very extensive process. This has been brought up before, and when you're looking at these therapeutic alternatives, which is normal in a cost assessment analysis, there's so much more that has to go into it. It takes months for these processes, and we're doing this in a very short period of time. I know my time is almost over. I have plenty that I could still weigh in on, but in saying that, please look at me too as a resource, as somebody who's an expert in health economics, in research, and also from the patient voice. I appreciate your time.
Thank you for being here. Do any board members have any questions of Tiffany related to, I guess, our Cosentyx review? I know we took the public comment after the review. But Tiffany, thank you for being here. So appreciate your time. And we are now moving forward to the Creon portion of our agenda. So again, I'll just reference that we did receive one letter from Albert Fardo from the Cystic Fibrosis Foundation. We've had one past speaker who was Lindsay Silva, a mother and primary caregiver of someone living with cystic fibrosis, spoke at the May 21st meeting. And we do not have any speakers signed up related to Creon for this specific meeting. So with all that said, Courtney, you have the floor to help guide us through our Creon discussion.
All right. Apologies for all the screen sharing flipping. But so last packet for this meeting is Creon. Going to high summary has 4 therapeutic alternatives with a 6% rate increase from 2018 to 2024. Cost to impacted payers and cost to enrollees. And again, the same as before. If board members have a specific section you'd like me to jump to, I'm happy to go there. Otherwise, I'm just going to kind of scroll through for potential conversation points or any other suggestions for improvements.
Can you stop there, please, and just scroll up a little bit? I can't read quite as fast as you scroll. Even though I know we've all read and seen this before. Just wanted to give everyone a moment to look. I don't have a specific question at this time, but if you could just leave it on the screen for a moment.
Were you looking at anything particular, Chair Bailey? Or
I just wanted to re-look at something. So I've seen what I wanted to look at. But if any others want to continue to look at this screen.
All right, hearing no additional feedback, I'm going to keep scrolling. Average.
Can you go back up related to WAC or AAAC on this screen? I just want to highlight that when we looked at the actual WAC of the drug increase versus the pharmacy acquisition cost piece, there's a very significant delta between the percentage percent increase. So again, where my mind goes when I see things like that is access. If something is changing on the pharmacy acquisition cost end, that's significantly different than the change in WAC, that is something that could create access issues. So that's just more a mere comment.
Yeah.
And I guess, Courtney, I'll continue my comment related to AAAC to reference that I am not suggesting that all those changes that impact pharmacies are manufacturer related. There are many other players in the supply chain that impact pharmacy acquisition cost of drugs. And for the record, I just wanted to clarify that.
Dr. Hartung, I see your hand up. Go ahead.
Actually, this table here that you have, this Creon is for CF. Is it used off-label for other? Does it have other indications? I guess I was kind of expecting it to be primarily a Medicaid, high use within the Medicaid population, and was a little bit surprised that there's extensive use in the Medicare population. I'm wondering if that's due to disability or I guess I was just surprised about the distribution of utilization across the payers.
Yeah, let me go down to the clinical. component, because we indicated if it had a off, no off-label use was indicated from the clinician. So I'm not sure how to respond to your inquiry, why Medicare and commercial have higher utilization than
Yeah, I
Medicare.
don't practice clinically, so I don't know if most of it's for.
Yeah, Dan, I mean, I can tell you from personal experience, I don't just see it for CF patients. I mean, we see it
Okay.
for cancer patients, like pancreatic cancer patients, or there's various different patients who we see pancreolipase getting used in, not just CF patient. At least in my clinical practice, I've seen that.
Okay, that's helpful.
It does make me wonder though, because like from personal experience, this is one where I've run into a lot of issues with prior authorization or step therapy or a patient converting over and having to leave Creon and go to a different pancreolipase product. So to see only 1% of plans requiring prior authorization or some sort of try something else first, that didn't align with kind of my own personal experience. John, I don't know if you have any experience with Creon or the pancreolipase products.
We see mostly other products used versus pancreas or versus Creon, excuse me. Yeah, pancreolipase products other than Creon are used or required to be used in most cases.
Yeah, yeah, that's exactly my experience. They have you use something else, and when patients are switching insurance companies or something, even if Creon was working for them, they either have to fight a lot to stay on the Creon, and the pharmacy tries to help with that, or they are forced to switch to Zenpep or another product when they switch insurances.
This is interesting because this is based off of the data call. Heather, correct me if I'm incorrect, but the prior authorization step therapy, that's all based off of the data call information. It should be, right? It's not from APAC. And we can't hear you.
I'm sorry. Can you hear me now?
Yeah.
Sorry. Yes, this is data call, not APAC.
And I guess just for clarification that the assessment from the data call is based off of only 11 carriers, so it may be different depending on carrier and plan type that may not have been fully captured within the data call, but appreciate the insight of what the clinicians are seeing in real time from that compared to what we received from carrier information. Is there anything that the staff can do to help kind of look into that? Any suggestions, or just be aware that it's a little bit of discrepancy? Okay, that's fine. Any other comments or discussion from the board?
I think the only thing I would say when you see some things in such absolutes, like such a low PA threshold for Creon, or conversely, such a high PA threshold for Cosentyx, it would give me cause for pause, right? Because like a lot of all these other drugs are coming in right around 36% require a PA. So when we see these really far outliers, I mean, from my perspective, some of that's a plan design thing, but when I'm hearing the clinicians see a lived experience that's different, that certainly makes me think.
And Shelley, I think two of the comments from the community had to do with lengthy prior auth processes. So OHSU put in there that there's there's comments about requiring prior auths. And again, that kind of lines up with my experience with it.
I appreciate that call out of information. Again, the data source isn't always completely accurate. You know, we work with what we got and what's reported to the best of our ability, just to create that baseline benchmarks.
Oh, and that was not a reflection of anything related to staff, just to be clear.
Yeah,
Which is-
totally, Courtney. That wasn't on you. I'm just saying it's different. The number that is in the data is just different than my own experience.
Yeah, no, I understand. All right, board. I'm not sure what else would be meaningful for you to look at or have a discussion on. I just wanted to provide a moment before we wrap up with the last bit of this. And I can hand that back to Chair Bailey to wrap up the rest of the meeting. So
thank you, Courtney. I'm just reviewing to see if I have any personal further questions or comments I want to add before we commence.
okay. And just a reminder, I do appreciate all of the feedback from board members today. I'm going to take my notes and be reaching out to a handful, like most of you, for additional feedback, especially around the rubric. I'm trying to set that up so it can be a strong utilized tool kind of going forward with these discussions and review packets. And if you have any ideas for recommendations, please bring those to staff as soon as you can, or to the next board meetings. We can start setting those up to be a meaningful conversation and to incorporate in a timely manner into the final end of your progress report. Right? If there's nothing else, I'll see you all when I see you. And thanks again for your information today.
Thank you, Courtney, for helping facilitate this as we go through things. I do want to lean in as a reminder to the information Courtney provided earlier in the meeting about referencing that now is the time for us to be, considering what type of recommendations we want to make as a board, and to have that fruitful dialogue throughout the remaining portion of this year. This is just my personal comment to my colleagues that we definitely lean into that opportunity and the time that we have to do this. So if everyone can continue to make that something top of mind to be able to provide to staff, I think it's very meaningful, and I want to make sure that we have sufficient time to discuss some of those things as we move forward with any recommendations that come out of this board. So just something I wanted to reiterate. But I do want to reference that our next board meeting is on September 17th, 2025. And again, for the record, it is at 8 a.m. And with there being no further business before the board, all in favor of adjourning the meeting today, please say yes. Yes.
Yes.
Yes.
Okay. I hear some yeses. Any opposed, please say no. Okay, meeting is adjourned, and we'll see everyone next month. Thank you.